Hello.
He's thinking of a beautiful song to play for you
Got it.
and the rest of the world that passes through Rome.
Imagine there's no heaven. It's easy if you try. No hell below us. Above us, only sky. Imagine all the people living for today. Imagine there's no countries. It isn't hard to do. Nothing to kill or die for. And no religion too. Imagine all the people living life in peace. Ooh, you may say I'm a dreamer, but I'm not the only one. I hope someday you'll join us, and the world will be as one. Imagine no possessions. I wonder if you can. No need for greed or hunger, a brotherhood of man. Imagine all the people sharing all the world. You may say I'm a dreamer, but I'm not the only one. I hope someday you'll join us, and the world will live as one.
Good evening, sir.
Hello.
Good
Yeah,
evening. Good evening.
yeah. Good evening, everyone. Should I start my presentation?
Yeah, Basu, you can start.
Yeah.
Sir, I need to introduce. Is it being
Okay.
recorded?
Yeah.
Okay. Very good evening to all, and I welcome you to this webinar on challenging uveitis cases. It is my pleasure to introduce Dr. Soumya Basu. He's a uveitis and retina consultant at LV Prasad Eye Institute, Hyderabad, and he heads the uveitis services of the LVPI network. Dr. Basu's research interests lie in understanding the interactions between infection and autoimmunity in the immune pathogenesis of ocular tuberculosis. He has received multiple competitive research grants, most recently the DBT Wellcome Trust Intermediate Fellowship in Clinical and Public Health Research. He has published widely in peer-reviewed international journals and has been a reviewer for nearly all major ophthalmology journals. Dr. Basu has been actively involved in framing the Indian Extrapulmonary TB Index guidelines. He has also been the principal investigator for several multicentric clinical trials. I'm very happy to welcome Dr. Basu, and we are eager to listen to him.
Thank you, Abhilasha. That was a fairly extended introduction. Thank you. So, without much ado, I think let's get started. Thanks to Dr. Vaibhav Sethi for giving us this platform. It was a nice beginning to the session, wonderful music. So I'll keep the short talk. I will keep the talk short. It's it's called Busting Myths in Ocular TB, and I've just taken two myths here. One is that the MON2 and the quantiferon test is supposed to be equal to ocular tuberculosis, and the other myth is that ocular TB is can present with any form of uveitis. And I'll start with the second myth first. So ocular TB actually has very select clinical presentations. It's not like it can present with any form of uveitis. And if you look at the Sun classification criteria, it includes 4 major types of presentations. One is the granulomatous anterior uveitis. Second is the serpiginous-like choroiditis. Third is the retinal vasculitis. And fourth, multifocal choroiditis in the presence of systemic TB. Now, I don't mean to say that these are the only forms of ocular tuberculosis, but it is mainly to highlight that not any uveitis can be ocular TB. So the thing that is common to all these presentations is that all of these have some evidence of granulomatous inflammation, and this has been shown histologically as well. This earlier study by Dr. Ankush Kavli shows that in serpiginous-like choroiditis, there is granulomatous inflammation. This was one rare case where histology of the choroid and the retina could be gathered, and it shows actual granulomatous inflammation behind. Similarly, we had published a patient with retinal vasculitis where you can see intraretinal granuloma within the retinal tissue. So all of these have some evidence of granulomatous inflammation. Now, along with this select ocular sign, you can also look for supportive evidence. And in the case of retinal vasculitis, we have identified 3 important supportive evidence. One is the presence of subvascular lesions, which you can see here in this picture, which can be active retinitis or a healed retinitis. The second is the presence of a new clinical sign which we identified, which we call as focal vascular tortuosity, which is within the area of the vasculitis. And the third is of occlusive retinal vasculitis, which can be understood both by the presence of hemorrhages as well as by the capillary non-perfusion on the fluorescein angiogram. Now, apart from these select clinical signs and the associated signs, you should also look for history of a TB contact. I think we don't spend enough time in asking for this history. This is not only a history of contact in the family or neighbors, but also found to be common amongst healthcare workers, migrant workers, barbers, grocers, etc., who are more likely to come in contact with people who have tuberculosis, specifically pulmonary tuberculosis. Now, the other clue that can be useful is the involvement of multiple tissues, especially in a patient with choroiditis. So either you see a patient with choroiditis having pain, which means that the sclera has been involved. There are no pain receptors in the choroid, which means that multiple tissues are involved, and that is kind of a clue that it could be tuberculosis. Similarly, If you see an OCT sign, which we call as the contact sign, then again, this is likely to be tubercular, where you see that the choroidal inflammation is now infiltrating into the retina. So all of these together should guide you towards the possibility of tubercular etiology. All of these increase what is called as the pre-test probability of the disease, and this, along with a positive Montu test or a quantiferon TB Gold test, should tell you that this is more likely to be tuberculosis. So what happens when you make a diagnosis in this way? This was a patient who came to us with this retinal vasculitis, an area of active retinitis, and you can see that within 2 weeks, just by anti-TB therapy alone, the vasculitis has cleared up completely along with the retinitis lesion. Similarly, this is another patient who came with fovea involving serpiginous-like choroiditis, a very poor vision of 20 by 250. Patient was a diabetic and had a history of TB contact at home 7 years ago. We treated this patient with anti-TB therapy with steroids as well as intravitreal Ozurdex injection. And you can see 6 months later, the patient has 20/20 vision, and you can see the lesions have healed very well, and residual pellet of the Ozurdex can be seen lying around. On the other hand, if these clinical phenotypes are treated with steroids alone, then you get into trouble, not in the beginning, but later on. For example, this was a patient who presented again with serpiginous-like choroiditis phenotype. Vision was 20/25. For some reason, the treating clinician thought that this can be treated with steroids alone, and indeed, 3 months later, the vision is 20/20 and the lesions appear to have healed. But if you look further on, 6 months later, the vision has dropped down, the fovea is gradually getting involved, there are new lesions that have come up, and the vision is now 20/50, and further down the line, 18 months later, the lesions have extended even further, and the vision has dropped down to 20/80. So this is the problem of treating these patients with steroids alone. They do require anti-TB therapy. The other myth that I want to bust here is that the Montu or quantiferon test is equal to ocular TB, which is absolutely not the case. Both these tests are mere symbols of the memory T cell response to a past TB infection, and they are unfortunately the only evidence of TB in our patients, which is very unlike other forms of TB where you get a microbiological evidence. So these may be positive in both active and latent infection, and even when the body has cleared up all the TB infection. So because these are just a memory T cell response. But the other end of the spectrum is that they may even be negative. If the body has not mounted a sufficient immune response, they may even be negative in active tuberculosis, and this could be up to 30% patients with extrapulmonary tuberculosis. So they should be tested only in the presence of a suggestive clinical sign and not in the presence of opposing clinical signs. And definitely Montu test should not be used as a screening tool for tuberculosis in any kind of uveitis. So for example, here is a patient who has a classic placoid retinitis pattern of syphilis. You are not going to test for Montu. Or a patient with non-granulomatous anti-uveitis with fibrin in the anterior chamber, not going to test for Montu. Any of these patients can turn up with a positive Montu test, and that could mean trouble because you will not be treating the patient with the exact treatment that the patient needs. It can be even worse if a patient with subretinal fibrin is not recognized correctly and a Montu test comes positive. You may end up causing a bullous RD in this kind of a patient. So the other end of the spectrum that I was trying to talk about is highlighted in this patient who came to us with a serpiginous-like choroiditis, active in the right eye and in the left eye, and completely scarred in the right eye. So this patient was Montu negative, and therefore we treated this patient with steroids alone, and actually the lesions resolved very well. but they came back with a recurrence, and which is when we added azathioprine, and they again resolved very well till the patient was lost to follow-up. The patient came back to us 2 years later with near complete scarring of the fundus, as can be seen here. And this is where we realized our folly and treated the patient with anti-TB therapy despite a negative MON2 test. And it's been 15 years since then, and the patient has not had any recurrence. So these two ends of the spectrum, one is a negative test in a patient with a phenotype of ocular TB, and the other is a positive test in patients who do not have a phenotype of ocular TB, were published by us in these two papers last year. I'm not going into the details of these papers, but this is just to tell you that MON2 test is not equal to ocular TB in either side. Okay. So to summarize, clinical signs should decide whether to test for the MON2 or quantiferon TB Gold test. The MON2 test is not a screening tool for uveitis workup, and it should be avoided in patients with non-TB clinical signs. A positive test is irrelevant in a non-TB disease, and a negative test does not rule out ocular tuberculosis. Thank you for your attention. Any questions now, or will they come later?
Thank you for the excellent talk, sir, and a lot of myths you have burst in this talk. I don't see any questions in the chat. So what is your advice for the younger like postgraduates or fellows who are interested in uveitis? If they see a case of granulomatous anterior uveitis, what all tests should be done and what should they suspect?
So granulomatous uveitis, broadly for a
Yes.
general ophthalmology clinic, I divide into three parts. One I call the TB sarcoid group. The second I call the viral anterior uveitis group, and the third I call the granulomatous uveitis with panuveitis group, where the recurrences tend to come as granulomatous uveitis. So the TB sarcoid group can be very similar, and there are clinical signs that will tell you that you might be dealing with either TB or sarcoid. And for example, a sarcoid patient is more likely to have peripheral anterior synechia and hypopigmented spots in the peripheral fundus. Those are signs of sarcoid. And then there are blood tests, chest radiography, which will tilt you either towards TB or sarcoid. Viral anti-uveitis, I ask people to remember the 3 P's. 1 P is the pigment, which is everything is pigmented. The KPs are pigmented. There is pigment dispersion in the anterior chamber, and the other P is the pressure, which is the intraocular pressure. So if you see pigment and pressure, think of viral anti-uveitis. And the third is granulomatous anti-uveitis in association with panuveitis, which could, of course, be any form of panuveitis, but I would specifically want to highlight VKH and sympathetic ophthalmia, where the recurrences may have only granulomatous anti-uveitis, and unless you look at the sunset glow fundus carefully, you will be missing out on the actual diagnosis.
So you showed one very interesting case of retinitis with vasculitis, which was treated with ATT. So do you regularly treat your patients just with ATT, or how long do you wait before you start steroids?
Yeah, so this is a little complex thing, and I don't advocate this thing of using ATT alone in every patient that you come across. Based on my experience, and this includes about 10 to 15 years of treating uveitis in Eastern India versus past 4 years treating uveitis in Southern India, I find that in Southern India, the chances of patient responding to ATT alone is quite less, as against Eastern India, where I see that the patients respond to ATT alone very well. So it depends on which population you are looking at, and this depends on the genetic makeup of the host. Overall, I've seen that in the East, Orissa, West Bengal, they respond to ATT alone very well. So you take a look at your population, and it's not every TB uveitis will respond to ATT monotherapy. I specifically find some forms of choroidal granuloma and this TB retinal vasculitis with the retinitis lesions responding very well to ATT monotherapy. And they respond slightly faster than in combination with corticosteroids.
Okay, so we have one question in the chat by Dr. Deena. She has written, "Thank you for the interesting talk. When would you inject an Ozurdex after ATT? When would you inject?"
Yes. So it's not that I inject Ozurdex very frequently, but it's typically in patients with serpiginous-like choroiditis, especially patients coming to us with unilateral disease. This may reduce the load of the oral steroids. We should remember that serpiginous is one condition that needs a ton of steroids along with the ATT. So giving Ozurdex reduces the load of oral steroids. Then in patients who are diabetics, we recently had a patient, which is very interesting. The patient came with serpiginous to another ophthalmologist and was getting treated with steroids again and again and again for every recurrence till he developed bilateral avascular necrosis of the femur. So when he came to us, he had already been treated for bilateral AVN. And what do we do now? Because we are starting ATT and there's a very high risk of paradoxical worsening with that ATT. So that one patient I treated with ATT and Ozurdex alone, and the patient responded very well. So briefly, unilateral disease, the patient and presence of any comorbidity should guide you towards Ozurdex.
Thank you, sir. Just one last question now. When should we suspect MDR TB? This is question by Dr. Namrata Gupta.
Yeah, I think MDR TB is a very difficult. Ocular TB is a very difficult diagnosis to make. Some things that point towards MDR TB. One is the patient has had a recent TB contact, which could potentially be an MDR TB. Second thing is that the lesion has not resolved at all. You keep giving steroids and ATT, and it's still there is persistent inflammation. That should tell you that you might be dealing with MDR TB. And the patient himself or herself has a chest lesion which is not going away with the ATT. So all of these together will tell you that there is a possibility of MDR TB. The MDR TB can be tested both by molecular and culture methods. The culture method is more accurate, but it's very unlikely that our ocular samples will yield a culture positive. So we only have our molecular methods to test MDR, and that comes with a catch, because not every molecular test, it could be a gene expert test or a sequencing test, but not every test is very specific. So just because the molecular test is showing a positive test for MDR doesn't mean that the patient necessarily has MDR.
Okay. Thank you, sir. So in the interest of time, we'll move on to the next speaker, Dr. Deena Badar, who will be talking on GPA story. She's a senior uveitis specialist from Cairo, Egypt. Over to Dr. Deena and Dr. Mayur.
Thank you all for being here, and thank you for the invitation. I shall share my screen. Okay, can you see my screen now?
Yes, Dr. Deena.
Oh, okay, all right. Okay, so I'm going to focus my talk today about a very interesting disease that we don't see often, and that is GPA. I'm trying to start. I know it's. Does anybody know how to start the presentation? how to start.
Dr. Deena, do you see that care written on your slide? Eye care.
Mm-hmm.
Below that eye care, you can see that little box that's there. Go
Well,
below.
the thing, the
Just next to the
the
minus, just next to the minus,
Just
Deena,
yeah,
on the
just next
bottom.
to the minus in the bottom.
here. No, not here. In
Now, or
the
you can go on the top where you have file, home, insert on the slideshow. You can start the
Mhm.
slideshow
Okay, very good. Yeah, I
from
knew there
beginning.
was a catch here. Thank you, Annie. Okay, so this is a case that I saw in Cairo, and it's been a few years now. This is a 37-year-old gentleman who presented to the Veritas service for a second opinion, and I'll tell you what has been going on. So the vision on examination when we first saw him was 0.7 in the right eye and 0.8 in the left eye. The AC was clear. There were no signs of active inflammation in the AC. The pupils in the right eye were reactive, but in the left eye, there showed some afferent pupillary defect. This is what the patient looked like. And this is, I think, is a very interesting and teaching case for this disease, where we can appreciate the thinning that and the amount of destruction that's been going on in the maxillary sinus on the left side. So, of course, when a patient comes in, you have to thoroughly review what's been going on. And obviously, he's been going through a lot. So he presented a lot of data to us. And so he presented in the beginning with maxillary sinusitis, and this was removed, and the pathology was very non-specific as a chronic inflammatory process. So the ENT people and the chest people worked him up, and there was also a mediastinal mass that was not very conclusive either. It was only an inflammation, consolidation, chronic inflammation. But at that point, he started to develop this disfigurement of the sinus on the left side. In the meantime, he presented with cystoid macular edema that was treated with a single injection of anti-VEGF. Now, what can we do? We have to look at the back of the eye and try to understand why he's having this edema, because an edema in a chronic inflammatory process is a concern. So we did the fluorescein for this patient, and as you can see, there are areas of vascular leakage in the periphery. The disc is hot, the cystoid macular edema, and there are pinpoint leakages starting in the mid frames and the late frames as well, of leakage in the periphery and in the posterior pole. In the meantime, he also suffered cystoid macular edema as seen on OCT. Now, when you come to the left eye, we cannot appreciate a lot of inflammation, but what we can appreciate is that the disc is hypofluorescent and the macula is thin, probably because of loss of ganglion cell layer. So what do we have now? We have a 37-year-old with a chronic granulomatous systemic inflammation affecting the sinus, the mediastinum. As regards the eye, there's retinal vascular leakage, recurrent macular edema in one eye. There's optic atrophy with an afferent pupillary defect in the other eye. So, and besides, of course, the maxillary sinus destruction. So for teaching purposes, these are the differential diagnoses that you can find in the book. Now, given the systemic findings, I think we are narrowed down to these three main entities: sarcoidosis, IgG4 related disease, and GPA. Now we know that it's GPA because I put it in the title, but let's work how we got to this diagnosis. In sarcoidosis, usually we will find chest lymphadenopathy. This was not an lymphadenopathy, it's just a chronic granulomatous mass. In IgG4 related disease, there's no intraocular inflammation. But in GPA, which we had the highest suspicion at that point that this is our patient, you have the nasal involvement, the chest infiltration besides the eye. So we think that the eye guided the diagnosis, besides, of course, the sinus necrosis that we saw that eventually led to the saddle nose deformity. This patient has been in our service for years now. Of course, and then, but luckily he hasn't suffered any renal issues, and he sometimes gets some arthralgias, which is typical of the disease. So this is a granulomatous necrotizing vasculitis that affects the small and medium-sized blood vessels, and it is a life-threatening condition. If you go to the diagnostic criteria, we have red painful eye, we have the nodules in the cavities, and we have the granulomatous inflammation. So what can a patient with GPA present with? They can present either with orbital or corneal or retinal disease or neuro-ophthalmological. And in our patient, he had the retinal/uveitic part and the neuro-ophthalmological part. It is very important because we see a lot of those patients, they present with scleritis, or at least every patient of scleritis, it is advised to work them up for GPA because it's life-threatening. But in my practice, and I've been doing uveitis for over 10 years now, I've seen very, very few patients with a GPA. In fact, I think this one was the most remarkable. So if we go to the guidelines for treating, and these are patients, of course, that we're treating in conjunction with our rheumatologist colleagues. So if you go to the guidelines for treating GPA, and our patient is a generalized form, the decision was to start cyclophosphamide with steroids. So that's what we did in order to induce remission in this patient. Is we started systemic steroids with cyclophosphamide and azathioprine, and for the eye, I decided to go for a subtenon triamcinolone. The patient did well, but 2 months later, he came back with graying of the vision in the right eye. We know that more than 50% of these patients can relapse on cyclophosphamide. So what did we do? Well, we worked up the patient. Now, OCT on its own was not enough to show any damage in the right eye. Remember that the left eye had already suffered the damage by the time he presented to us. But in the right eye at this point, there was nothing on OCT, but the field was very telling. The visual field was very telling in the right eye, and this was also confirmed on VEP. So if we go back to what has been happening now, this patient has failed cyclophosphamide or has relapsed on cyclophosphamide. So it was now the decision with the rheumatologist to discuss MabThera or rituximab. Now, IV rituximab is quite expensive in Egypt, so it was a big decision, and I think the eye was the guidance. This is a chimeric human monoclonal antibodies against the CD20 on B lymphocytes, so it's an anti-B drug. It has shown to marvelous response. 63% of patients reached remission, and a great success rate in both uveitis and scleritis. So what happens is that patient gets 4 infusions per year at day 0 or day 1, and then 15 days later, and then they wait for 6 months and they repeat the same course. On follow-up of this patient, there is a remission of the optic neuropathy that has happened in the right eye, and his VEP got better, and the patient still sustains to this day on rituximab. So I think it's a very interesting case with these teaching points, because GPA is a serious life-threatening condition if left diagnosed. And remember the subtle deformity and the necrosis that has been going on in the maxillary sinuses. This is very telling of the disease. Now, immunomodulatory treatments have significantly improved the outcomes because this is a fatal disease. I think in our case, the ocular involvement guided the rheumatologist that there is a relapse on cyclophosphamide, and it was not enough to keep the patient cured. And also a teaching case for our younger colleagues, any case of recurrent CME, unexplained CME, it is very important to search for the cause. Thank you very much for your attention, and hope to see you in Cairo soon.
Thank you, Dr. Deena. very interesting case. For the purpose of the audience, I just wanted to you to just recapitulate the treatment part with rituximab, because I think uh, with the availability of rituximab now, these agents are more and more being used in various forms of uveitis and scleritis. So if you could just go back to that slide and just recapitulate that part as to how what is the time frame in which you have given it. I think that's the one thing that is there. Of course, from the other part is obviously that both times, even at the time of diagnosis and even at the time of relapse, it was the eye that pointed towards the fact that the disease was still unstable.
Sure. So we of course we don't do this on our own, right? We need our rheumatologists with us, because this is the rituximab is serious and GPA is even more serious. So let me share. Okay. So I think this is an important slide too, and because it tells us that for this particular rheumatological disease, and for most of them, I'm sorry, there's some issues. So you have to first induce the remission, induce the remission. Okay, this is taking some time. Okay, induce the remission and then maintain the patient. So for our patient, what we did, and this is the protocol for treatment with rituximab, is that you start with 2 infusions, 15 days apart, then you wait for 6 months, and then you repeat the same course. Then you reassess. Now, our patient has been under treatment, I would say, for 4 years right now. He's still on azathioprine, he's still on steroids. But I think the total of MabThera that he has taken might have been 4 courses in total.
Okay, okay, okay. So the disease is such that despite being on azathioprine, he's required rituximab. And even while rituximab is on, we are still feeling the need to use azathioprine.
This was the decision of the
Yeah.
rheumatologist, although the eye has been quiescent and great. I don't see him as often as I used to right now because he's been quiescent, but maybe this has changed. I mean, it's been more than 6 months now, and his eyes have been doing great.
Okay, okay. Thank you, Dr. Deena. That was an excellent case and extremely good learning points, and especially the fact that, even at the time of diagnosis and even at the time when the relapse happened, it was the ophthalmologist who could, really help the rheumatologist first come to the diagnosis and then point out that the disease is unstable. So, thank you very much. And I think we can now move on to the next case. I think the next case presentation is by Dr. Anirudh. Is it?
I'll take over, sir.
Yeah. Okay. Thanks a lot, Dr. Namatra. Please take over.
So, next talk is by Dr. Anirudh Agrawal, who is a renowned VR surgeon presently working at Cleveland Clinic, Abu Dhabi. He's a prolific researcher and has published over 200 peer-reviewed manuscripts in international literature and book chapters. In addition, he's also a member of the International Collaborative Ocular TB Group, which is the COTS. And we'd like to hear more, sir, about the topic serpiginous like choroiditis when immunology and epidemiology has a mismatch. So over to you, sir.
Hi everyone, good evening, and thank you Pan Ophthalmologica team for this kind invitation and honor. Especially shout out to my friend Dr. Vaibhav Sethi. So I'm just continuing, I think, on the previous talks. My topic is going to be a mix of the first 2 talks. The case is going to see where you have a serpiginous like choroiditis and treatment with rituximab and immunosuppression, probably. So moving with the case, so this is a patient who came to me with a history with severe systemic history, left ear pain, hearing loss. There was left-sided ptosis and generalized headache. This was in May 2022. He was otherwise a very healthy 40-year-old male from Pakistan. And this patient also had other symptoms such as pain in the knee, arthralgias, and he was diagnosed to have enlarged retropharyngeal nodes. And the left ear had recurrent effusions, and so much so that he required a tympanostomy. So he had multiple courses of antibiotics, and ear corticosteroids in the ear, which was followed before and after the tympanostomy. During the course of his stay, he was hospitalized and he had an extensive laboratory workup. So I've just sort of summarized the more important ones for all of us. So this is he was having a very high IgG4 level, and he was PR3, which is ANCA positivity, and his levels were 7.4. He was negative for MPO. Rheumatoid factor was negative. Serum ACE levels were normal. ANA normal, and his comprehensive metabolic profile and blood counts were normal. He was negative for anti-CCP, and at that time his chest, CT, and abdomen were normal. So, he was started on high dose of oral corticosteroids, and after 4 months of treatment, his ear, definitely the middle ear effusions improved, but he developed an intractable cough. This appeared when the oral corticosteroids were tapered and they were made to less than 20 milligram per day. So he was on very high dose, 50 milligram, brought down to 20 milligram. Thereafter, this patient, developed, this was the CT when the patient developed the intractable cough, and it was noted to have a cavitatory chest lesion. The patient had air fluid levels and had high CRP. So the CRP was 72 and the ESR was 119. So very high evidence of systemic inflammation. And this time his quantiferon was indeterminate and the MON2 was positive 12 millimeter. So he underwent bronchoscopy with bronchoalveolar lavage, and there was evaluation also of the pleural fluid, and it was tested extensively for AFP, for PCR, for fungi, bacteria, even non-tuberculous mycobacteria, and all of this was negative. And at the same time here you can see this nasopharyngeal mass which was present in this patient. Now again, his systemic steroids were decreased further from lower down from 20 milligram, and at this point this patient developed decreased vision. So he was almost on 5 milligram of oral steroids and he presented with decreased vision in both eyes. And you see here, this was how he looked like. So there were serpiginous-like lesions in the right eye. They were active on autofluorescence imaging. And the left eye also. In the left eye, in fact, he had lesions which were threatening the fovea, active lesions. And here you have the OCT picture also. You're showing you the outer retinal loss, and you have choriocapillaris ischemia and lumpy bumpy RPE, very typical of serpiginous-like choroiditis. So of course, the diagnosis was serpiginous-like choroiditis in both eyes. His TB PCR was negative, like I said, from pleural fluid, from bronchoalveolar lavage. Sputum was negative. He had a positive MON2 and quantiferon was indeterminate. It was, of course, repeated, still indeterminate. He belongs to an endemic country and he has chest lesions with nodes. So, I entered all of this information on the COTS calculator. So, the collaborative ocular TB study has the COTS calculator, which is available for all of us to use for free. And I entered the information, I entered the phenotype, endemicity of the patient, his results. And in the IGRA, I said not done or unknown because it was, indeterminate. And the chest X-ray was, of course, positive based on the cavitatory lesion. So the COTS gave me a very high probability that the experts all over the world would initiate anti-TB therapy. And so it was a high consensus for initiation of ATT. At this time, the bronchoalveolar lavage, again, like it was repeated, was negative, diagnostic thoracocentesis was done, biopsied. The pleural tissue was biopsied, was negative for PCR for non-caseating or caseating granulomas. And so at this time, we made a decision to start the patient on rituximab infusion and azathioprine. And so we did not elect to start anti-TB therapy. There was absolutely nothing in favor of TB except a 12 millimeter MON2 test. So in fact, his azathioprine was subsequently increased, and I elected for a corticosteroid implant in the left eye. So you see here, this is from baseline in the left eye, and in 3 days, there was probably some interval improvement. But you see here, over 10 days and over 3 weeks, there was near complete recovery in the left eye. The autofluorescence of the lesions gradually decreased and completely disappeared. And at 3 weeks, the lesions were completely healed. The right eye also showed improvement, but there was no implant in the right eye. This was just on systemic rituximab and azathioprine. And you see here, in 3 months, the lesions completely resolved. So he was subsequently maintained on azathioprine or Imuran and 2 years of rituximab. He's still 1.5 years of on rituximab now, and low dose corticosteroids 2.5 milligram prednisolone per day. It's been 1.5 years now of follow up. This patient has developed no recurrence, zero recurrences so far. So the phenotype of serpiginous like choroiditis, it can be associated with some rare autoimmune diseases like the PR3 or ANCA vasculitis. So far, I don't have any other patient of systemic vasculitis presenting with serpiginous like choroiditis. And now the question about the COTS calculator and the decision to treat based on COTS calculator alone, you may go wrong. You may not be in the right direction because it is not just the radiology and lab, the treatment for TB or serpiginous like choroiditis. And especially when you are faced with a situation where you have immunological profile and epidemiological profile which is not matching. In such cases, in rare scenarios, the COTS calculator can be wrong, or it can be in the opposite direction. And often you require to do extensive systemic workup, often invasive, to really go in the right direction. So with this, thank you very much, and I'm happy to discuss and take any questions. Thank you once again, Pan Ophthalmologica team.
Sir, a very interesting case, sir. My question is, could this patient be given a therapeutic trial of ATT like an option?
I've never done that before. We've never done ATT as a therapeutic trial because it is very difficult to ascertain the treatment benefit, because generally we'd give ATT with corticosteroids. So we don't know which is working. In this particular situation, there was no evidence to start anti-tubercular therapy. So again, if I were to go back and repeat the same thing, I would not start ATT.
Okay. Any other questions from the other moderators?
Annie, this is Dina.
Hi, Dina. Yes.
It is a very interesting case, and the more interesting part is that they did not need any coverage of anti-TB treatment before starting immunotherapy like rituximab, did they?
So generally the protocol our infectious disease follows is starting off ATT only if quantiferon is positive. We do not start anti-tubercular therapy solely based on MON2. Even if you have quantiferon positive, they would generally start a single drug therapy for the latent TB only. So because the quantiferon here was indeterminate, done 2-3 times, there was no evidence of TB bug anywhere, so it was not started.
Okay, very interesting case.
Yeah, this is my first time to see, in a systemic vasculitis, and of course, I think in many institutes now they're starting to use the COTS calculator. I know that it can be downloaded as an app on your phone, and so it can be helpful for at least the routine cases.
Yeah. Thank you.
Thank you.
Any comments, Basu, sir?
No, this was absolutely fascinating. We recently had a patient of necrotizing scleritis who had a cavitary lesion. And actually, I had discussed with the rheumatologist who told us how to distinguish between cavitary lesions of GPA versus those of TB. And, while the talk was going on, I was frantically, Googling it up, trying to find out what are the differences. So Anirudh, if you know that part, that will be good.
Difficult questions, but GPA and TB are often coexist and they mimic each other. GPA cavitatory lesions usually are not apical, they are basal. TB is more, it loves oxygen, so
Okay.
it usually goes to the apices. So location is one difference. Secondly, the GPA lesions in the chest are necrotizing lesions. Their wall has lots of necrosis. TB usually presents with granulomatous inflammation, whereas in GPA, so these are mostly seen on the slide. On the slide, you can differentiate between the two. And of course, some immune markers can be positive in GPA, but there is a lot of overlap, and radiology alone is often inconclusive.
I would like to intervene. Very nice presentation, sir.
Thank you.
Actually, number of times it has happened that clinically we see that the case is typical serpiginous choroiditis, and still the quantiferon gold comes negative. So,
Yes.
I mean, still we sometimes insist the physician to start on AKT and stuff, and we see patients responding. So, do you think that like quantiferon gold negative is means we really don't need to start on AKT and think of the other things, or maybe we can give a trial of empirical AKT as well?
See, I'll just repeat what Dr. Basu sir said before
Hmm.
and clarify one thing, that if you have an Indian patient from an endemic country presenting with serpiginous like choroiditis, it is highly suggestive of TB as the etiology. In the absence of quantiferon or immunological tests for TB, where you don't have quantiferon or MON2, if you have quantiferon negative, probably you will do a MON2 and you will also do a chest CT. If none of it is positive, there is no rationale to start ATT, I believe, in my opinion. So there is no point in pushing somebody, and there is nothing called as trial of ATT. It is an actual treatment that you will give because it's a full course, 4 drug. So unless you have some immunological or radiological evidence, it could be just one test. It could be only quantiferon in the setting of an endemic country like India, then you are justified in starting ATT. But if nothing is positive, I don't think you are justified. Also, you must remember the counterpoint, which is you could have quantiferon positive sarcoid. Okay, so you have to look at several aspects before you push for ATT. And ideally, you should take into consideration also the results from COTS and from the phenotype. Like Basu sir is here, he has described the perivascular choroiditis. So, that should be considered. Then Dr. Vishali, Dr. Amod, they have described certain predictors of TB. So you should look at the phenotype and at least have some radiological or immunological evidence to start.
Yes, sir. Thank you, sir.
Thank you.
I think from here onwards, we'll move on to the next presentation. So I'd like to introduce Dr. Sybil Demirel, who is the professor in the Department of Ophthalmology in Ankara University. So she's going to share her insight on the topic PPB in an eye with calcific toxoplasmosis, sequelae, and rhegmatogenous RD. Please welcome Dr. Sybil. Over on to you, ma'am.
Hello, good afternoon. It's a great pleasure to be here with like you, esteemed colleagues. I'm going to talk about today actually a surgery, persplana vitrectomy. I am mostly interested in medical retina and surgical retina. I am not a uveitis specialist like you, but this is the one I picked for showing in this session, and it is about the congenital toxoplasmosis and related complication such as tractional and rhegmatogenous retinal detachment. And as we all know that the toxoplasmosis is one of the leading causes of posterior uveitis, and which is infectious. And the most clinical presentation of active toxoplasmosis is the whitish edematous necrotizing retinochoroiditis and maybe old pigmented scar just next to it. And as we all know that the vitreous inflammatory reaction is usually associated with this situation. Sometimes it's very silent, sometimes very serious. It depends on the immune status of the patients, as we all know that. But as a vitreoretinal surgeon, sometimes we have to do vitreoretinal surgery for these cases, and the uveitis departments usually send these patients to us for such reasons. For example, vitreous opacities, sometimes choroidal neovascular membrane, epiretinal membrane, etc. But when we talk about, especially in congenital one, it can be happen like the rhegmatogens and tractional retinal detachment both. And even if it's not frequent, sometimes it can happen. And according to those series, I just searched in the literature to find something used in my presentation, and I found this literature, and according to that, actually, when we talk about the congenital toxoplasmosis, they usually present hypertrophic scars in the periphery, and sometimes it can complicate it with vasoproliferative tumors like structures, like a big whitish mass complicated with vascular tissue or invaded with vascular tissue coming from the choroidal side. And because of this situation, sometimes some tear might be happen around this hypertrophic scar according to the vitreous inflammation. So what I want to share this case with you. This is a 32-year-old male diagnosed with actually congenital toxoplasmosis, and he has been following since like he was 18 years old with strabismus, exotropia, and glaucoma, and he was treated only once during that period in another hospital for the uveitis attack in 2017 with the Bactrim and the oral steroids, and then he was admitted to the ophthalmology department with recent visual loss, our ophthalmology department with recent vision loss, like shadowing in some part of the eye in his left eye. So our residents consulted the patient to the uveitis department, and he was put on oral Bactrim 2 times a day, and that's all. Actually, just conjunctival hyperemia. There's conjunctival hyperemia and nothing too much in the inside eye actually. Right eye visual acuity just 1 meter counting finger, and for the left eye 0.1. When I saw these patients because of the retinal detachment, this is the situation. As you see here in the right eye, there is the congenital, there's a big chororetinal scar, pigmented atrophic chororetinal scar in the macular area, secondary to congenital toxoplasmosis. In the left eye, however, this situation is a little bit serious, more serious. As you see here, there is a big hypertrophic scar located in the periphery, and also there is some fibrotic tissue on the temporal side, and probably this is because of this is the reason for the rhegmatogenous retinal detachment. There is already tractional detachment in the periphery, but since the patient has recent history of visual decline, probably there's something happening there. This is the rhegmatogenous retinal detachment, I believe. Even I couldn't find the break location. And when I first proposed the surgery, he refused to have it because this is the only one eye for him. But after 1 week, he came to the hospital for seeking any further treatment like surgery because of the deteriorating visual acuity. And I'm going to show you the video actually, how this is serious and what I did for these patients. And actually, I was surprised how the situation is serious for these patients and complicated the situation. This is a 27 gauge surgery. I did combined surgery. First, I didn't put the intraocular lens during the surgery just because I wanted to be sure about the posterior part of the eye, and I wanted to be comfortable with on the periphery, and that's why I clean all the vitreous remnants just back of the lens and the peripheric area and started with vitrectomy. As you see here, there are many layers of vitreous and also the fibrotic tissue all about the macular area. And the situation is extremely serious in the inferior part and also the temporal parts. And I believe that when I started to trim the fibrotic tissue on the temporal side, I will find the responsible breaks, because as you see here, the retina is extremely thin, necrotic on the temporal side, and under that fibrotic tissue, the subretinal, viscous subretinal fluid, as you see here, right now, here, is coming out from that break on the temporal side. This is 27 gauge surgery. I don't actually offer this kind of small gauge surgery for this complicated patient, but this is the one what I wanted to try, 27 hyper with cutter. It's the cut rate 20K cuts per minute, and that's why it's very efficient. And also the design of the probe also is a little bit different from the previous one. The opening part is very close to the tip, and that's why it's very comfortable to go under the fibrotic tissue and trim and lift at the same time, like a probe or like a pick. That's why I tried that one, and it worked well. As you see here, it's almost calcific scar tissue in the periphery. It is not possible to get rid of all the tissue just by cutting by the occipitome. Not possible. And in the first part of the surgery, I tried to understand where is the remnant of the vitreous, and is still the posterior hyaloids attached on some part of the retina. And after I put some triamcinolone acetonide, I understand where is the attached vitreous, posterior hyaloid. After I remove all of them, started to try to trim all the fibrotic tissue all around the retina, which is the very interesting part. As you see here on the temporal side, as you see here, I cannot relieve all the traction on the retinal area, and that's why I decided to do retinotomy and retinectomy for that area. Still try to get as much as retina from this fibrotic tissue. Try to save retina as much as possible. As you see here, this whitish area, that there is no retinal tissue over here. This is totally fibrotic. But what I'm doing now, try to save those parts, and that's why finally I did retinotomy and retinectomy. And before I doing that, I always usually do diathermy, prevent from bleeding. And you see, now I'm more comfortable than the previous stage. I trimmed all the peripheric part, but still the probe couldn't eat them up, this whitish area. But still, I can do vitreous-based shaving, etc., and getting rid of all the vitreous step by step. There is a really strong adhesion between this fibrotic tissue and the retinal part. I did retinectomy almost like maybe 160 degree or something, which is surprising. As you see here, whenever I pull the retina to the vitreous side and see what's happening under the retina, and I assume that there are some subretinal tissue or something, but this is retina. There is a big fold, retinal fold there, almost two layers of retina there, and that's why I have to get rid of the second layer of retina under this first layer of the retina, because otherwise the probably laser would not work. Since this plication, I trim all the second layer of the retinal tissue under the retinal area to get healthy laser scars all around that place. And finally, with Decalin, I attach all the retinal area without any suspicious place. It's all attached now. I do heavy laser usually when I cut the retina and do the retinectomy. As you see here, it worked well because it's attached totally. And now the final part, I see some traction around the vascular arcade since I want to do some laser spots over there. I do bimanual surgery and little bit relieve the traction as much as possible and trim more tissue. And finally, I do laser around the vascular arcade, and this is the final situation of retina. After air fluid exchange, I put 5,000 centistock silicone oil. And now the patient just came yesterday after 2 months, and the retina is still attached. And I'm planning to the silicone oil removal and the IOL implantation probably in upcoming month. Thank you very much.
Thank you so much, Dr. Sibyl. It was a very nice presentation, nice video, and surgically you've done excellent. I just
Thank
wanted
you.
to know how many degrees of retinectomy have you done in this case?
Usually at least what I prefer, usually at least if I want to do retinectomy, usually at least I do 180. But since you know there is some fibrotic tissue all around there, and also it's very close to vascular arcade, that's why I couldn't do 180. Otherwise, probably it would bleed a lot. That's why in this case, particularly in this case, I did 160 or something. Yeah.
All right. Audiences, you're free to ask any other question. So post-operatively, do you think that we need to restart on any antibiotic as per Toxo, and what have you followed the protocol?
Yeah, Neha, I also wanted that question to you all guys, the uveitis guy. And you think that this kind of surgery can cause some recurrence, or should I use, how can I say, the prophylactic bacterium or something like that for a long time? What do you think about that?
Yeah. The
Maybe
question.
Aniruddha is here.
Yeah.
Yeah, Sibyl, you're brave, you're a brave surgeon. Well done. So nice to see you. So I would not start in this particular case, start Septron Bactrim, because I think the lesions were all fibrotic and healed. I think you did start preoperative.
Yeah,
That was,
yeah.
I think, enough. For
Okay.
Toxo, I don't think we have any guidelines.
Okay. Thank you, Aniruddha.
And sir, if it is an active case, you would prefer with the clindamycin or the Bactrim itself? Matlab, what is your preferred choice of drug?
For a detachment or just Toxo?
Just an active Toxo going into the sequelae and
No,
stuff.
I usually supplement oral with intravitreal Clinda, especially if it is macular. I do supplement.
Or oral and intravitreal clindamycin, that's all?
Clindamycin, yes.
Ah,
So
okay. The
oral
monotherapy. You're using monotherapy.
mono, yes, clindamycin. Intravitreal Clinda along with oral therapy.
Oral therapy, okay.
Yes.
I think we don't have any other questions in the chat box. So, yeah. I think it was a nice interactive session, and we are already over the time. Thank you all the speakers and all the moderators and the audiences. It was really lovely to have you all, and we really enjoyed the talk.
Thank
So,
you.
yeah.
Thank you.
Thank you very much. Yeah.
Yeah.
Thank you very much.
Bye-bye. Have a nice day.
Bye-bye. Have a nice day.
Yep.
Bye.
Same. Bye-bye.
Thank you all.
Dr. Mohit sir, session 2, you can start.
Yeah, hey. Should we wait for people to join, or can we just start?
Sir, I have video of the.
Yeah, so I was told that hello.
Thank you very much for inviting me to present on PVAC, peripheral vascular anomalous complex. And these are my disclosure. And this recent editorial, my group and I, we summarize a number of degenerative microvascular changes in the retina of normal subject or aging subject. And this was isolated or associated with other diseases, including age-related macular degeneration. And well, the forerunner of these changes, microvascular changes, even in normal subjects, as PVAC. PVAC that I had the privilege to describe first more than 10 years ago. This is a case of PVAC that is characterized by microvascular changes with reduced perfusion, absence of perfusion, very localized, and secondary changes like large microaneurysm that also are isolated and related to the area of microvascular changes. Well, this is characterized also by extensive exudation and hard exudates. We can apply OCT angiography to PVAC, and we can nicely see that there is flow inside this large aneurysmal changes along with hypoperfusion. We can also face with similar changes to PVAC, but in absence of exudation. So this is the non-exudative PVAC, and we recently described this entity. And this original description of a non-exudative PVAC, we also hypothesized that this is an initial step in the future development of exudation that is more typically encountered in patients with PVAC. And so everything can start with a non-exudative PVAC, and over time, the development of exudation in the end makes PVAC or exudative PVAC. This is a beautiful example in which you can nicely see that at the beginning we have a non-exudative PVAC, and then over time there's a continuous exudation, and so exudative PVAC. What is the treatment for exudative PVAC or PVAC? Well, there's no standard treatment. In general, exudative PVAC does not respond to anti-VEGF. In this example, you can see that after loading of aflibercept, there was no resolution of exudation, and overall deletion appeared the same. Laser treatment, where standard laser treatment has been reported as the most effective treatment for exudative PVAC, but also this may fail to reduce the exudation or have a resolution of the changes, and particularly the aneurysmal changes that are associated with exudative PVAC. We recently described a case with a complete resolution of exudation and closure of the aneurysmal change after application of topical diclofenac. Well, I must admit that I'm not sure that this was strictly related to topical diclofenac, but I can tell you that the real most effective treatment of exudative PVAC or PVAC is the spontaneous resolution. We have a number of cases that over a variable time, well, they develop this closure of the aneurysmal dilation. Just like we are familiar with large arterial microaneurysm, they may close spontaneously, and this then is characterized by resolution of exudation. But again, we don't know when this may happen, so this may happen in a very few weeks or months, or even after years. Recently, DRAMA is being described. DRAMA is deep retinal age-related macrovascular alteration. As you can see from the original description, this is very much looking similar to PVAC and associated with intermediate MD, so drusen, and something that's very similar to PVAC. And indeed, in the larger series that we published about exudative PVAC, well, combination with intermediate MD has been already reported. So DRAMA in the end is PVAC. Recently, exudative non-neovascular AMD has been described, as you can see from the original publication by the New York group. Well, we may have AMD in absence of neovascularization, but that may present with exudation. This has been reported to respond to anti-VEGF. Well, recently we described what we call exudative non-neovascular GA. In eyes with GA, we may find exudation, so cysts, exudative cysts, but these are fluctuating and may resolve spontaneously, so without any need for anti-VEGF. This is just an example to show you how after just 1 month, you may detect a resolution of this exudation spontaneously, so no hurry in treatment, and this has been recently accepted in retinal cases and brief reports. So now we move to GAIN. GAIN is geographic atrophy associated intraretinal neovascularization. I will show you a couple of cases. So this is the case of an AMD female patient that was detected with GA, and this was the clinical picture for GA, and this is a fundus autofluorescence for the atrophy of this patient. So you can nicely see that we have no exudation, that we have large serous areas, so GA. But when we perform OCT angiography, we can nicely see that there is a kind of neovascular loop, in this case in the inner retina. So this in absence of exudation. This is again, this is this neovascular loop that is strictly located in the inner retina without any connection with the deeper retina and with the choroid, differently from what we used to see in eyes with type 3 neovascularization. So this is an important differential diagnosis with type 3 neovascularization. In this slide, you can see how instead type 3 MNVs present with this neovascular tuft that is typically located at the level of deep capillary plexus and just beneath the deep capillary plexus, even in absence of exudation. So now we move to case 2. This is again a patient with GA and AMD. This was the clinical picture for the left eye, so we can nicely see these small areas of GA just above the fovea. And this was the clinical FA picture. And this is the ICG. In the magnification, you can nicely see that also in this patient, we can detect a neovascular loop that is located still in the inner retina, but in this case with some exudation. When we look more deeply at this patient, we can see that there is a double, triple layer sign at the level of the Brooks membrane and RPE that may represent type 1 MNV that is causing this exudation. So now we look at the OCT angiography, and the OCT angiography nicely discloses this neovascular loop still located at the level of the inner retina. This is definitely different than the neovascular tuft that we have in exudative type 3 MNVs, with the exudation that is strictly related with the communication or the contact between this neovascular tuft coming from the deep capillar plexus and growing towards the RPE and the sub-RPE space that is associated with development of exudation, as we described in nascent type 3. And nascent type 3 and actually describe this continuous growth of type 3 MNVs from the deep capillary plexus down to the RPE and the sub-RPE space in order to develop the exudation. So we have here a comparison face-to-face between gain in absence of exudation and non-exudative type 3, so type 3 MNVs with their typical neovascular tuft versus the neovascular loop, also in absence of exudation, as we know typically happens with nascent type 3. And here we have a face-to-face comparison between a gain, an exudative gain, versus a nascent type 3 and an exudation with the typical tuft versus the neovascular loop. Case 2 then was treated because of exudation with a single anti-VEGF injection, and just 1 month after, for a long time period, the patient was without any recurrence of exudation. But after 5 years, the patient presented with a dramatic hemorrhage and exudation that was rather related to an aggressive type 1 MNV that probably was already there and was the original cause for exudation. And even after more than 20 anti-VEGF, unfortunately, there was this dramatic progression, probably not related strictly to gain. So to conclude, gain is a novel entity that is characterized by a neovascular loop that is located in the inner retina. We don't know still the clinical prognostic significance of gain, and we are happy to collect more cases from all over the world. This gain was recently published in Graves. Thank you very much for the attention.
Yeah, that was a great talk, a recorded talk by Dr. Giuseppe. I just had, he's unfortunately not with us. I'm just going to pose 3 quick questions to, I can see Dr. Raja there, and so maybe I can, have a quick couple of questions to Sir. So, Sir, would you treat a non-exudative gain patient with anti-VEGF, or would you wait for exudation to appear as we generally tend to do with other forms of neovascularization? Also, since in his talk he brought up the fine differences between a nascent type 3 MNV and gain, would you also go ahead and treat a nascent type 3 MNV? Because it's not exuding at that point in time. So again, just to quickly summarize the question, would you treat nascent type 3 MNV? And would you treat gain, which is exudative, or would you treat gain, which is non-exudative also?
Yeah, those are, I mean, a very nice presentation, and I think a lot more needs to be learned in terms of the overall natural history of a disease. Now, whenever we talk about interventions, when to treat and what to treat, it's important to know the natural history of the disease as an untreated form. Right from the macular photocoagulation study to even Marina and Anchor, unless we know the natural course, we may be carried away by any form of treatment for any disease. So I think these are very important findings, very important questions. At this time, I don't think we have enough evidence to say that we should start treating patients who don't have any exudation, whether it's gain or other types of intraretinal neovascularization or even non-exudative AMDs, choroidal neovascularization for that matter. If there is no subretinal fluid or intraretinal fluid with the CNVM, we are right now not treating them. But obviously, these could change over time if we know the natural course of the disease over time. Yeah.
Yeah, thank you. And just a question to anyone who'd like to, share their experience on how they would be treating or how they treat PVAC or PVAC-like lesions. Would do they just observe them? Do they straight away jump to laser? Do they give a trial of anti-VEGF, trial of steroids, combination? Just anybody wanting to share their experience of how they treat PVAC and PVAC-like lesions.
Yeah, so PVAC are slightly resistant to anti-VEGF, but obviously if there is no exudation, I'd still withhold any treatment. But if there is exudation, anti-VEGF, some of them are very close to the fovea. It's a tough call in terms of laser, but anything more than 500 microns or even 300 microns probably, we may try a low energy laser as well in some of these lesions, like you hit microaneurysms. But yeah, if they're not exudating, probably we'll just withhold them.
Fair enough, sir. I think we still don't have the kind of biomarkers to say that which lesion is going to progress at what rate, and I think we wait for the exudation to try and treat. Thank you, sir. And with that, I would invite you, Dr. Raja, for your talk. Eagerly looking forward to your talk on the role and the effect of brolucizumab in patients of CSC without choroidal neovascular membrane. Dr. Raja, please.
Yeah, so let me just bring up my slide. I hope it's visible. Yeah, so I'll be talking about brolucizumab in chronic CSR, which is a randomized controlled trial, which is currently ongoing. But enrollment is over. But we'd like to share the interim results, and I would like to acknowledge and thank my co-authors here in this trial. Now, simple CSR is very well known in terms of the presentation, natural course, and is very well known for its spontaneous resolution in about 3 months with good visual acuity. But some of these patients may not resolve, and there can be a persistent fluid accumulation, subretinal and intraretinal fluid, and it may be associated with metamorphopsia or micropsia. And when it becomes chronic, of more than 6 months typically, it can be a significant challenge to treat these patients with any form of treatment, traditional or even the newer treatments. And this classification by Chablani and Cohen is now useful for understanding this disease a little bit better. This study of brolucizumab is not for the simple one, which is listed on the top, but for the complex CSR as well as which is persistent for a long time. And the key here is the intraretinal fluid on the right side column, which you see. In simple CSR, you typically have only subretinal fluid, whereas in complex CSR, you may have intraretinal fluid. So these are the cases which pose a significant challenge, and this is where this study is currently indicated in. The various treatment options are PDT, micropulse laser, mineralocorticoid antagonists, but some of them have limitations, or in fact, there has been evidence to show they are not efficacious, such as eplerenone is not now found to be useful, and most of us have now stopped using eplerenone. Even micropulse laser has questionable benefit. Now, these are the kind of cases which are extremely challenging. Chronic complex CSR, where you have multiple areas of autofluorescence changes over many months to years. And you see the OCT, you have intraretinal fluid, skytic changes, which can be extensive with hyperreflective dots intraretinally as well as within the choroid. The ICG shows multiple areas of choroidal vascular hyperpermeability or hyperfluorescence. This is one of our first patients who was on eplerenone and had intraretinal fluid, subretinal fluid, serous PD as well. But over time, even after 2 months and after multiple other visits, this patient had persistence of fluid. In fact, the fluid has increased in the right eye. The vision has dropped further. And this is over 2 years of multiple micropulse laser and eplerenone. And this was a time when we had just started getting brolucizumab in India. And when we looked at the various trials of anti-VEGF, what we found was the resolution within a few months, let us say 1 to 6 months, was not very good. Although at 2 years, there is in the study by Kang et al. With bevacizumab, at 2 years, 88% resolution has been noted, but it's not an RCT. And we know that in chronic CSR, if you just leave it long enough, 2 years, 3 years, the fluid can resolve on its own with significant atrophy of the fovea. So we are looking at something within 3 to 6 months in terms of an outcome, beyond which the natural history by itself can have some resolution. So that's why, but do remember, recall these numbers, 31% resolution with PDT or even with bevacizumab and aflibercept at 1 month, it's just about 30% or less resolution. So we'll come to our study results and compare it with these. So our study was a randomized controlled trial in the absence of a choroidal neovascular membrane. And this was a 1:1 randomization between brolucizumab and placebo. The primary objective was reduction of macular fluid by 20% or more. The secondary outcomes were improvement in visual acuity, and also subfoveal choroidal thickness, microperimetry, and ICG leaks, apart from NEI VFQ. We did all these investigations: visual acuity, OCT, Opta, fluorescein, and ICG, microperimetry, and VFQ-25. And patients were eligible for crossover from the control arm if the fluid still persisted, they could cross over after 3 months to the injection arm. So this is the baseline characteristics of our patients. There was no significant difference between the two arms, and a lot of patients had both intraretinal and subretinal fluid. So what we found at 1 month and 3 months was 72% resolution in the treatment arm at 1 month, and only 12.5% in the control arm. And recall what we had showed in the table. At 1 month, the best outcome so far with the other anti-VEGF molecules have been just about 30% at 1 month. And in fact, at 3 months, we were above 80%. And this is complete resolution of fluid. This is not just the 20% reduction which we were trying to achieve. This is a complete resolution of fluid. So that was significant, but this is just an interim analysis because we have enrolled 42 patients. The current results are of 22 patients. And we also had a few patients who crossed over into the control arm, and 6 out of 7 eyes in the control arm, when they were given brolucizumab, had complete resolution of fluid at 1 month. So 3 months of persistent fluid, and we gave an injection as crossover, and in 1 month after the injection is completely resolved. And this is the OCT's central subfield thickness. This blue one is brolucizumab arm. You see the significant reduction in subfield thickness. The red is control. In fact, in the control arm, the subfield thickness increased a little bit. If we did not give the injection, the fluid increased at 1 month. And in the subfoveal choroidal thickness as well, you see the choroidal thickness significantly reduced in the injection arm. And there's hardly about 12 or 15 micron difference in the untreated arm. I'll show you a few examples. This was a 54-year-old, 1 year of eplerenone and 1 micropulse laser, had significant intraretinal fluid in schisis after 1 year of treatment. Opta did not show CNVM, and we gave an injection of brolucizumab in 1 month. You can see the complete drying of the retina, and the inset is the baseline that is before the injection. You can see the dramatic change after 1 injection of brolucizumab. This is another patient, 55-year-old, 2200 vision, had multiple sessions of micropulse and focal laser, was also on eplerenone for more than 2 years. And at 1 month, you see the complete resolution of intraretinal fluid, but the PED still persisted, serious PED. Now, brolucizumab typically flattens PED as well very nicely. There's a slight reduction in the PED, although it was a bit surprising that the PED did not completely resolve, but the intraretinal fluid completely resolved at 1 month. And at 5 months, this patient had a recurrence of intraretinal fluid. We repeated the injection, and this time the intraretinal fluid as well as the PED completely resolved. And this is a patient who was in the control arm receiving placebo. At baseline, 1 month and 3 months, we can see the subretinal fluid is persisting. The intraretinal fluid is persisting at 3 months. And this is when we decided to inject this patient with brolucizumab. And this patient, in 1 month after being crossed over, had complete resolution of the fluid. So in conclusion, brolucizumab achieves a very high rate of resolution and a very rapid resolution of macular fluid, and it is a promising solution in the absence of any other effective strategy for chronic CSR. Although we believe that more needs to be done in terms of visual acuity improvement, because a lot of these patients do not improve substantially in terms of vision, but unfortunately the photoreceptors are already damaged in these patients because of the chronicity, but at least in the long run, they may not have further deterioration. And we are hopeful of completing the final visit of our patients by November this year, when we can share the results of the full data set of 42 patients. And we have published the pilot in seminars earlier this year. This was presented in AP, VRS, RO, and also we had an instruction course in retina. But again, thank you for the kind attention.
Thank you, sir. Great talk, as always, and actually, very difficult to actually get all of these studies prospectively out, and so kudos to the work that you're doing on this. I just had, one question, sir. Any thoughts on trying to compare, instead of using Pegenax, maybe using, something like a faricimab, instead of this, given that there is maybe not significantly in our country, but significant safety profile, effect, at least globally in the published data?
That's a great question, very important question, Mohit. And I would say that's something which should be done. Although in India, brolucizumab is, it's commonly used in at least resistant cases for any disease. But I've been told that, jokingly, when this was presented in New Retina, so this is BRICS, it's time to do a FRIX study of faricimab in chronic central serous. So I think you're right that, if someone wants to proceed with that, I think it may be showing beautiful results as well. Yeah.
Fair enough. Thank you.
Dr. Raja, it was wonderful to hear your talk, but I think we are constrained for time, so I'll like to get our last speaker in, Dr. Marcelo Casella, joining us all the way from Brazil. Dr. Marcelo, welcome. His talk is on CSCR and bacillary layer detachment, the clinical characteristics and risk factors. So, Dr. Marcelo, once again, an honor to have you, and if you're ready, you can proceed with your presentation.
Yes, thank you very much. It's a great honor to be here. Thank you, you, Devendra, and Valibav. I'm gonna share my presentation. Can you see my slides?
Yes, we can see your screen.
Okay. This is a study. We have a big study group all over the world. The bacillary layer detachment and central serous retinopathy. I don't have disclosure to do about this study. You all know about CSS, central serous. It's just a neurosensory detachment with the fluid accumulation without a tear. Bacillary detachment is different. Is the separation of the photoreceptor layers, initially published in 2018. I'm going to share some knowledge about this. It's very interesting finding. You can see the split of the neurosensor, different in CSR patients. This patient was submitted to PDT, and can see the split of the photoreceptor layers, the inner and the outer segment. This was previously described in postmortem eyes by Leeuwenhoek in 1722. There is this separation of this photoreceptor, splitting the photoreceptor layers after the diff. You can see in some specimens their pathology. But it was Meta that introduced the term bacillary layer detachment to describe the separation of bacillary layer from the remaining retinal layers. This was in a patient with toxoplasmosis, And this has been described in many patients with serous detachment and inflammation. We had described CSR in patients recovering in the inflammatory phase of COVID under steroids and sometimes antibiotics. Could see in some patients this bacillary detachment associated with central cirrhosis. Also, our friends from Spain published this large series of CSR and bacillary detachment after PDT. Our objective was to put together all patients and see what are the risk factors, what can find about this, what's happening with these patients. We focused on several things, and it was a retrospective observational case control study. You have a really good matched control group. And the inclusion criteria was CSR with diagnosis and the OCT finds of bacillary detachment, and the exclusion criteria was cases that were mimetizing bacillary detachment, but they didn't have this. We were very, very critical about this presence of this bacillary detachment. Sometimes you get confused with fibrin, coagulation, and PED. We got 37 patients with 40 control patients as control. And so what did you find? Find that most of our patients had more psychiatric disorders than the control group, and most of our patients were more prone to have been using steroids, corticosteroids, okay? Here's a case that you can see the bacillary detachment, the split of this photoreceptor layer, you can see here. And this patient was under steroids. Also, many patients had been treated previous, especially photodynamic therapy, and they had this inflammation with this splitting of the photoreceptor layers. Okay, as you can see here, a beautiful image. Sometimes you think it's fibrin, sometimes you get fibrin, but it's different. This split is very characteristic and gives some whitening in the retina, but most of the finds are on OCT, okay? Also, we found that our patients with bacillary detachment, as you can see here, this patient had lupus and was on corticosteroids also. The choroid is thicker than the control group. Both had thicker choroid, but the bacillary group had a thicker one. So BALAD is a biomarker, suggests a severe CSS presentation. It's a transient condition. Here is the patient with COVID, in the inflammatory phase of COVID. After, you can see some fibrin here and a beautiful bacillary detachment. We got off the corticosteroids, and the patient improved also from COVID, and the retina went good in this patient. So we believe there is, as in the other pathologies like ARADA, placoid, that they are more prone to have bacillary detachment and serous detachment. Maybe you have this CSR with inflammation. Also, there is this important choroidal thickening that's more intense than in control group. So BALAD could be a worse clinical presentation, more comorbidities, is more aggressive disease. It should have less favorable results after treatment. We're still looking for this result. Our study had limitation. It's a retrospective nature, small number of cases, a lack of a longer-term follow-up. We plan to study more, looking for this BALAD as a biomarker for severity. We would ask more people to contribute to our studies to get this a more good data. Thank you so much.
Thank you, Dr. Casella. It was a really interesting study and an interesting talk. I think your conclusions have been quite, well borne out that it is a biomarker for disease severity and maybe resistance to treatment and recurrence after treatment as well. I invite any of the other panelists, speakers, or moderators to give their suggestions or, sorry, their comments, or if they have noticed similar findings.
Yeah, that's a wonderful presentation. So while I have noticed BALAD in some patients CSC, especially with corticosteroid use, but I don't have the experience of the follow-up of these patients. Is there, what would be the preferred choice of treatment in these patients with BALAD? Is it different from those without BALAD?
First one, we take off thank you for your comments. First of all, take off the steroids if it's possible. No? We use many kind of treatments. We're out of Visudyne, now we are getting Visudyne here in Brazil. So Visudyne is the best treatment. You can get BALAD after Visudyne treatment, after PDT. But these cases were not so bad. The bacillary detachment improved and they got better. But we try laser, we try focal laser and sublimiar laser also in our patients. We're looking for faricimab also. We are interested in using faricimab. I don't know if we're going to get good results. No, we don't have any longer the brolucizumab here in Brazil. I would like to try.
Okay, thank you. Thank you so much.
Thank you very much.
Thank you once again.
If you can send your cases, it would be good for us, the bacillary detachments that you have.
Yeah.
Okay?
Sure. Thank you.
Thank you.
So thank you, Dr. Casella, and I thank all the speakers of this session. I think we're just in time to hand over the session to the next group. And the session moderators, Dr. Aditya Sudharkar, Dr. Ashray Nayak, and Dr. Neeraj Sahu, you may take over the session.
Thank you so much. Good evening, sir. Sharma, sir, good evening.
Hi, Aditya, how are you?
How are you, sir? All good?
Shall we start?
Yes, we can start, sir, without further ado. Hello, Dr. Ashray.
Asher was same city. Hello to you.
So I think you are kicking off proceedings anyway, sir.
Yeah, I'm not sure how my connection is, but still I think
it's excellent, sir. I can
me?
hear you very well.
It's okay. Okay, perfect. So with your permission, shall I share my slides?
Please, sir. You don't need my permission.
Oh no, I do
So
definitely.
it's visible and you're audible.
Okay, perfect. Okay, so first of all, thank you, Weber, for having me here in this excellent, I think, power-packed faculty and very wisely chosen faculty from across the globe. So I'm going to talk about the recent consideration of ellipsoid zone as a primary endpoint by the FDA, which is an interesting development which has happened in probably last couple of years. And before I proceed further, these are my disclosures. I do not have anything to disclose for this particular presentation. So this was one of our paper that we recently published discussing the role of ellipsoid zone as a surrogate efficacy endpoint in clinical trials. What could be the ramifications? So we had discussion with some of the experts who gave the suggestions that whether it is a good idea to have this and what could be the problems in having this. So those I would discuss it probably at the end of the presentation. So if you really look at last 2 decades of retina, we can happily say that these were the golden decades of retina. And thanks to predominantly two innovations, one was pharmacotherapy front, which brought us anti-VEGF therapies, and another is a diagnostic front, which gave us OCT as a diagnostic modality. And pharmacotherapy revolution, if you look at, it was going parallelly because we have seen companies trying to bring a different kind of innovation in terms of designing different type of monoclonal antibodies, trying to give different molar dosages so that we can reduce we can reduce and extend the interval. So that's what the target. And another front which is now developing is biosimilars because of the financial burden which was seen with the innovative therapies. On the another front parallelly which was happening was the treatment protocol. So treatment protocol, many of our clinicians across the globe, they try to work around different kind of dosing schedule which can give both extension as well and as far as even good efficacy as well. So these were proactive and reactive regimes which were tried. I'm not going to go into the details because it's a wise audience which is well versed about these protocols. So coming to the point that what has happened in all these phase 3 trials, of all those molecules which I described in last couple of slides, majority of them were approved with the help of these two endpoints. One was the BCVA gain and another was the central foveal thickness change. So central foveal thickness change was chosen because it was easy to replicate, consistent. So that's what FDA liked. And FDA always wanted that I need a functional parameter. I need to see that how a patient gets improvement for its function. So that's where BCVA comes into play. But as the entire field is progressing towards newer therapies, and if you have realize, I think we all are retina specialists, we all know that wet AMD definitely has poor outcomes, but dry AMD is something which is much more wider, and probably the area of need is much more in dry AMD, and we never had any kind of effective therapies for dry AMD except AREDS2 regime. But still, AREF2 regime we were writing, but still we do not know, how important it was and how effective it was. So thanks to the researchers across the globe, who could work around the complement system. So ultimately we did, get some therapy in the form of pegcetacoplan, which was targeting C3, and avansicaptad, which was targeting C5. and US FDA gave approval of these therapies, and predominantly the endpoint was area of GA progression. It was objective endpoint, again not really clinically meaningful. So there were some hesitancy in many clinicians when these therapies got approved, that whether really I need to give this for a long time if I'm not really seeing any clinically meaningful difference. I think Peter has done a lot of work on that. I think probably he might be a right person to highlight that, how clinically meaningful, endpoints we could achieve with the help of these kind of criteria. But essentially, we could achieve, GA progression in terms of the area measurement, reduction. So definitely a progress was made, and that's how the science progresses. So probably that was the right way to go. And now if you look at, there was a disconnect, as I said earlier also. So EMA did not give approval to Apellis. The reason was, one of the reasons obviously was that there was some adverse events which were there in this particular therapy compared to the other one. But again, when EMA gave a decision, they had their point that we need to see some kind of clinically meaningful difference whenever we approve any therapy. So that was again one of the point. So over the time, again, researchers have realized that non-complement targets could be researched, because complement is not something which has a real direct correlation. So that's where we are in now. There are some mitochondrial related therapies which are into the second phase or third phase trial, and recently that's where the ellipsoid zone topic came in, where Stealth Biotherapeutics, when they discussed with the FDA, and they could convince FDA that ellipsoid zone attenuation could be an approval clinical point in dry AMD. So this completely opens up a kind of a different zone that where we would go from here, because this is again a point with the help of recent imaging that we could image. I think Jay would be a right person to comment on that, how AI would be help us to really analyze this, because still we do not really know that how the data would be analyzed. If you really talk about the ellipsoid zone analysis, whether we are going to measure the intensity or thickness or width, how, because as of now, in my opinion, whatever I could discuss with David, Saraf, and the other group, is still the consensus is really poor. Different groups have different algorithms, and the results are not really same from the different groups. So we need to see how the data would be generated. But it's a welcome move by the FDA that we see some kind of imaging endpoint other than CFT, which is coming into play. I think this slide, all of us know that how Rick Spade, he has really redefined that whatever initial classification was inner segment, outer segment junction, how flawed it was, and ultimately the ellipsoid zone was the one where a lot of mitochondria were lying, and ultimately that layer which we were calling as inner segment, outer segment junction for quite some time in the initial years of OCD classification. Now we happily all are convinced that it is an ellipsoid zone, and we have reached so far that ellipsoid zone is now being considered as one of the trial endpoint. So now from where we started, now where are we heading to? So pros and cons, if you really see, with the help of this, you might see some of the increased approvals in preventive pharmacotherapy. Means, as I discussed earlier, there are some companies, which are working on the mitochondrial therapies. They would be happy to see, this criteria being used and approved by the FDA. But there are cons, because, retinal therapies and an entire function from these therapies is not dependent on only one particular point. So it's a kind of a multi-target function. So we really cannot rely completely on one specific endpoint. In that way, there are different approaches which a lot of companies, smaller companies might be working on. This could be a setback for them if this is fixed as a criteria for them as well. Means I do not know, probably Jay and Peter, they are there, so probably they can comment on this much better than me. So probably the path forward could be a conditional approval on the structural endpoint, and you can give approval if functional benefit is proven in the phase 4. I think this is probably the way to go over the time, but I would be happy to hear from Jay and our colleague. So I think that's it from my side. So thank you once again very much.
Yeah, thank you, sir. That was very enlightening. And this is we have progressed from actually having an optical histopathological section to identifying individual layers to doing something beyond histopathology, because the ellipsoid zone, as identified, perhaps has never been looked at so seriously by histopathologists, retina specialists. So now, and again, whatever you said made complete sense, because even if you look at whatever publications we have, not just vis-a-vis AMD or geographic atrophy, that even for surgical outcomes following macular hole. So what they say is that ellipsoid zone only assumes importance in areas where the external limiting membrane is intact, or so on and so forth. So like you said, this is in the early stages, and we don't. I mean, we look forward to hearing Dr. Jay if he's here, and how they plan on taking this forward.
Ashley, do you have any comment?
I don't have a comment on this, because to have an ellipsoid zone as an endpoint looks very logical, but at the same time,
illogical as well.
No. How do we quantify its continuity is a big caveat in its how we grade it and how do we make it, whether it is like present or not. So
yeah, no, that's what he referred to during the talk, that it's still in its nascent stage, and the length, the whatever, just absence or presence.
Yeah, I mean, I had this discussion with Phil Rosenfeld and David Saraf together in this URETNA, and I had the same question, Ashay, that how do we really quantify this, and how do we really get to the answer in terms of whether I am looking at the intensity, or I am looking at the area, or I am looking at the width. So what I am looking at. So both of them, they said, we have 2 or 3 centers, reading centers, from where we would get answer, but I think both have different algorithms in place. So your answer is not really same. So I think AI is developing. I was hoping Jay was there. He could have, I think, commented on that. So overall, once FDA gets the data after entire phase 3, I think probably that's where we would know, how robust it is and how easy it is. And Peter also, I think, can, because having a great experience in GA, Peter can really comment on this, because he is there, and very well connected with the research which is happening in this direction.
Dr. Neeraj, if you would like to add something, please.
No, I think we can we'll wait for Dr. Peter's opinion on it. Dr. Ashish has already mentioned most of the points regarding the evolving nature of EZ quantification. Dr. Peter, you have any comments on it?
I think
anybody, Devendra or Dr. Devendra?
I just wanted to add here, AI is only as good as the data. So if the data is quality of the data is not great, and I think AI can't do much. So the same biomarkers like drill or ectopic inner foveal layers, the quantification is quite cumbersome. even though yeah, EZ has only the presence or absence of it. Maybe I don't know whether adaptive optics and true photon OCT and all can help. But as of now, as Dr. Ashish already alluded to, I feel with the current UNet or RelayNet algorithms, the presence or absence can be easily quantified, but not about the quality of the ellipsoids.
Yeah. So thank you. And if no further questions, maybe we can go to the second topic if Dr. Jay has joined.
Dr. Jay is having work today, so I think we have a recorded video, and if we
Then
can
perhaps
play.
we could invite Dr. Peter Kaiser.
Yeah.
Oh,
Hello, everybody. I'll be talking about innovations in artificial intelligence in ophthalmology. These are my financial disclosures. None of them are relevant to the presentation. However, we own a startup called Netramind Innovations, and I'll be briefly talking about one of the softwares for AMD prediction, which is owned by this company. In next few minutes, I'll be talking about introduction to artificial intelligence, current applications of AI in ophthalmology, what are the limitations, and what are the future directions. Let's start with brief introduction to artificial intelligence. As we all know, artificial intelligence is the ability of computer systems to perform tasks that are normally require human intelligence by leveraging algorithms, data, and computational power. Machine learning is one of the branches of artificial intelligence which is primarily used in developing systems or algorithms that are trained on large data sets to make decisions and acquire novel skills. Deep learning is a type of machine learning that employs multi-layer neural networks that mimic those of the human brains. In today's day, we are mainly using deep learning methods in medical imaging, which we'll be discussing more in detail. What is the difference between machine learning and deep learning? In machine learning, we require a labeled data set where we require an expert which helps to do feature extraction as well as classification before we train the algorithm. But in deep learning, we don't require an expert, but these algorithms can do the feature extraction as well as classification, sometimes in supervised as well as unsupervised manner. Let's talk about more popular deep learning models. What is CNN? CNN is a convolutional neural network which is useful for image processing. It uses series of filters. We are now using GAN network, which is generational adversarial networks, which is consisting of two neural networks. One is discriminator and the other one is generator. This networks are usually used for creating images, which has a significant importance in ophthalmology. We are also using NLP, which is also called natural language processing. It is useful for language comprehension as well as documentation, including large language models such as ChatGPT, which is again used commonly in day-to-day life. What is transfer learning? It is a model designed for one task that can be inserted as the starting point for a separate task. Again, transfer learning is used commonly in ophthalmology because we also use multimodal imaging data as well as data coming from multiple devices. If we really look into the AI application in healthcare, it has been there for many years. AI has been used in logistics such as inventory management as well as supply chain management, data management. AI has also been used in automation of billing, optimization of scheduling. We are intensively using medical AI in medical imaging in identifying pathology, quantifying disease progression. We also use AI in streamlining diagnosis process as well as patient monitoring. And nowadays we hear about wearable devices, which many of the patients, such as diabetic patients, are using. This all is based on AI, which has been there for many years now. Let's look into AI in ophthalmology. How is the workflow? We all use multimodal imaging such as OCT, fundus photograph, corneal topography. So these images need to be pre-processed before we really start using them into training models. This could be of three types. A supervised learning is where the expert is labeling the data and training the models. Unsupervised learning is when the expert is not required and the data is not labeled. The algorithm learns from the images itself. And there could be a reinforcement learning, which is a machine learning technique that trains software to make decisions to achieve the most optimal results. The reinforcement learning uses a trial and error learning process, which usually human use to achieve the goals. So these are three ways of training the models, but we sometimes use semi-supervised, where we train some data and also use that data for unsupervised learning as well. So let's talk about AI in ophthalmology in multiple diseases. Let's start with cataract. AI has been used in cataract detection as well as quantification of nuclear sclerosis, posterior subcapsular cataract, just by looking at slit lamp photograph as well as retroillumination images. This has also been tried using fundus images to screen for visually significant cataract with an AUC of 0.91 to 0.96. AI has also been used to improve the IOL calculation formulas. What about corneal diseases? CorneaNet is one of the deep learning algorithm which has been used to learn from anterior segment OCT in patients with keratoconus and identifying keratoconus with an accuracy of 99.4%, and therefore AI could be used in diagnosing keratoconus as well as for screening for keratoconus. Deep learning systems have also been used for automated keratitis classification based on slit lamp as well as smartphone images, and these algorithms are used to differentiate between bacterial and corneal ulcer just by using the slit lamp photographs. AI has also been used in glaucoma screening, diagnosis, and prognosis. And as you can imagine, that glaucoma is based on imaging so much, so therefore the AI is really useful in identifying referable glaucomatous optic neuropathy as well as identifying glaucoma as well as predicting glaucoma progression based on visual fields as well. Let's talk about retinal diseases. As we all know that now FDA has approved two algorithms for diabetic retinopathy detection. One is the IDXDR and the other one is IART by iNuke. And these algorithms are based on deep learning network, which are useful to identify diabetic retinopathy with an accuracy of almost up to 90%. What about ROP screening? Deep learning methods are also used in identifying the ROP using fundus photograph as well as classifying, and are based on these the accurate referral can be done from the peripheral centers. AI is also used for AMD detection, where the multiple features were identified by using deep learning methods on fundus photographs such as large drusen, pigmentary abnormalities, and late AMD by using ARES dataset. These algorithms have also been used for fellow eye conversion by using OCT with an accuracy of 80%. What about identifying the wet macular degeneration? And there are deep learning methods which have been applied to predict visual acuity in response to anti-VEGF therapy in these patients by using these OCT scans. Eye images are not only used to detect ocular diseases but also systemic diseases such as neurodegenerative diseases. These are some of the papers which have used AI methods as an indicator of the risk of cognitive decline as well as differentiate Alzheimer's patients from retinal photographs with the presence and absence of amyloid on their fundus photograph. Ocular images are also used to predict cardiovascular diseases. These are some of the publications where they have used the retinal images to predict the risk of myocardial infarction as well as identify the presence of coronary artery calcium deposit, which can be a predictive factor for future myocardial infarction. So there has been a lot of concern about the privacy, particularly when we are talking about AI. So the possible solution for this privacy issues could be foundational models, where foundational models are pretty much a self-supervised learning to create labels from the input data. This means no one has instructed or trained the model with with labeled training data set. Therefore, it will help us to create data sets without any privacy issues. And what is federated learning, which is also called as collaborative learning? It is a decentralized approach to training machine learning models. It doesn't require an exchange of data from client devices to global servers. To global servers. That means that if we really combine the federated learning and foundation models, we will be able to advance the field and prevent and preserve the privacy and achieve a scalable AI systems. So what are the limitations? Current limitations are in particularly in ophthalmology, that these data sets which are available are inclusive of only certain populations. So we do not have a diversity in our data sets, as well as we are concerned about the reliability. There is no explainable answers to many of these output, because many of these models were using black box approach, where we are not sure how the outputs were generated. However, there are a lot of ways we are able to explain the AI outputs, which we will learn with time. And there is definitely an issue of image quality, such as artifact, which also can be influencing the output. And as we discussed earlier, that there is definitely concern about privacy as well as data protection, and how do we deal with the informed consent from these patients where we are using the data. So with this, I would conclude saying that AI is here. AI is here, very much here, and we are yet to learn to adapt AI, as well as there are many questions which we need to answer in terms of safety, explainability, trustworthy, as well as regulation. With this, I would like to acknowledge my lab and the funding agencies which have supported some of our work. This is our team at Choroidal Analysis Research Team, which is focused on AI-based solutions. Thank you so much for your attention.
Firstly, I welcome Dr. Jai for this webinar. It's extremely insightful presentation on AI. So I would request him to talk, give some insights into his area of work on GAN, the generative neural networks, and how he's using in his choroidal imaging, because we all know he has a lot of applications on choroidal imaging. To start with, I would request Dr. Jai to give some insights on how he's using algorithms.
Thank you. Thank you so much, Ashray. So nice to see you. Thanks to the organizer for inviting me for the presentation. I'm glad that I could share the video, so at least people could hear it, because I'm in the operating room. So, but I could still steal some time to be here. Thanks, Ashray, for the good question. And I think that the GAN networks have been here for quite some time now. We have been using GAN networks for last 3 years. And we have used primarily the GAN networks mainly to predict the imaging, how it is going to go. For example, that we have been doing some work where we want to predict that how this GA, or the geographic atrophy, is going to look in 2 years or 5 years, because as you are aware that now we have some GA treatments available in the US, but we aren't sure that how to pick up these cases, who are the fast progressors, who are the slow progressors. And we believe that picking up the prediction using GAN network could actually be helping us to identify the fast progressors and where we will be able to start treating them sooner. And in addition to this, we are also using GAN networks even for the wet AMD patients, where we are trying to predict that how the response to anti-VEGF is going to go. But one of the challenge with wet AMD is that because these patients, or I would say now the patients have so many treatment options that predicting that whether if you are kept on Eylea, how your scan is going to look, what if I introduce Vabysmo in between, how it is going to change. So these are some of the very practical challenges with wet AMD, but I would say that the predictive analytics still has a significant role in identifying the GA cases, differentiating whether they are slow or fast progressor, when their fovea is going to get involved. And also we are working on picking up, identifying the cases who have the higher probability of advancing from intermediate AMD to advanced geographic atrophy. So at least we will have some clue how it is going. But before I end this question, I would just make a comment that in our experience, the GAN networks are not the best option or they're not the best treatment for this because they have their limitations. We are still doing some post-image processing because the image quality which comes out of GANs is still not that great. But now we are switching our workflow, moving from GAN outputs to diffusion models to improve the outcome. So there is always something new coming up, as you're aware.
Thank you, sir. One personal question is, in Octa, there is always some time invested in segmentation from UNet algorithms to RelayNet algorithms, where the kind of segmentation have improved. Is there a possibility of your work where the deep learning models can come on board in every OCT machine to give us the segmentation directly as an output? Is there a possibility like that, or again, is the data is very complex to process such image sets?
Ashay, I think that every company, every device company is actually trying to come up with their segmentation algorithm, which are very much based on the AI-based approaches such as UNet. Now, obviously, people have gone ahead of UNet because UNet gives you an initial good output, but it does not really work very well with the disease data set because one of I'm not sure if you are aware that we have started a company now which does AI-based image analytics, and one of the product of our company is building up a segmentation algorithm for each layer because you probably are aware that now FDA is aiming to make easy segmentation or easy zone loss as one of their clinical trial outcomes. So I'm sure that many companies are working towards it, including us. So we have realized that the unit does a good job with normal or relatively normalized, but it starts feeling terribly with diseased eyes, particularly with GA. When the hypertransmission is increasing, they don't do really well. But to answer your question that, this is why we really need to work together with the industry, where we can give our constant feedback and improve their algorithms. And I think this is like a very exciting time where AI is incorporated so much so into our systems that, we will have better and better results. So I'm very hopeful towards that.
Thank you, sir. Niroj, anyone has any questions for Dr. Jay?
Good evening, sir.
Yeah,
Greetings.
Nice to
No,
see
sir,
you,
I
man.
think it was quite comprehensive, and I think you're on the same path as Elon Musk. So when he tries to
No,
use
no.
Neuralink to
Not
connect, stroke patient. I mean, this is retinal tissue as an output of the brain. So eventually, I think we are progressing in that direction.
Yeah, it is very controversial to compare yourself with Elon Musk. I would just
No,
stop
well,
there.
with the concept, if not with Elon Musk, with the concept at least.
So no
Yeah,
political
maybe.
affiliations. You're not
No. I mean,
insinuating
this is pure science, right? I mean, there is no politics involved.
Great. Good. Anything else, guys?
Sir, from India, of course, we have some data sets like Kegel's data sets and all. So do you use any data sets particularly, any recommendations? Because you are part of
So
ABOS, and so where we
So
can.
it is very I'm glad that people ask these questions that there are so many open source data set, but if you really take my opinion, we have not been very impressed with the available open source data set. And I think this is where I think we differ because we primarily work with the real life data set. So that really makes your algorithm robust because even in the open source data set, they are still not, the disease data set is still not of great quality. We have access to many of these open source data set. In fact, when the student starts working with us, we request them to, start working with open source data set. But at the same time, we feel that, what we are building up, we are lucky that we have almost 20 years of data set from both Heidelberg as well as Zeiss, and we have maybe more than 1 million OCTs. So we have a lot of longitudinal data set, which is definitely boosting our algorithms. So the only thing challenge, because I know you work in this area, the biggest challenge is the data curation and preparing the data set. That takes really long time, but I'm pretty sure that it's a time which is you have to just put the right ways. The one more thing which I feel, and my suggestion to you is that once you start building your own data set, you will learn a lot. You will, because we have a couple of publications came out just while struggling with the real life data set, like the quality check, the GAN networks were used to synthesize the missing data. So there was a lot we learned while doing this. So my usual recommendation is work with the real life data set. That is going to teach you a lot.
Okay, sir. I think we are running bit on time. Thank you for all the
Great.
insightful talk. Can we have Dr. Peter's video coming up? Dr. Niroj, want to?
Yes, it's my privilege to
Thank you, guys.
welcome our next speaker.
Thank you, sir. Thank you.
Thanks, guys.
Thank you,
Bye-bye.
Thank you, Dr. Jay. So our next speaker is Dr. Peter Kaiser. He's the Chair of Ophthalmology Research and Professor of Ophthalmology, Cola Institute, Cleveland Clinic, Lerner College of Medicine, Ohio. He'll be speaking on what's next in dry AMD. Over to you, Dr. Kaiser.
It's my pleasure to give you an update on the emerging treatments for dry age-related macular degeneration. Here are my financial disclosures. Here are some of the emerging treatment strategies to treat dry macular degeneration. They include reducing oxidative stress, increasing neuroprotection, reducing toxic byproduct accumulation, visual cycle modulation, replacement using stem cells, suppression of inflammation including complement alterations, and what I call other approaches. The first thing we know is that as we age, cardiolipin in the mitochondrial membranes are damaged, leading to oxidative stress. If we look at mitochondria in age-related macular degeneration patients versus age-matched controls, the cristae and number of mitochondria are reduced. A product by Stealth called elamipretide is a subcutaneously injected drug that binds to cardiolipin, restoring mitochondrial structure and function. So how do we image this effect?
In fact, in a phase 2 clinical study, there was a statistically significant reduction in the total EZ attenuation, and this outcome will be used for the phase 3 clinical study, which will be starting shortly. Beta amyloid has gotten a lot of press, especially in the Alzheimer's world, and the parallels between Alzheimer's and macular degeneration are very obvious. Beta amyloid oligomers are found within the vesicles of drusen, and this can lead to activation of complement, increased pro-inflammatory mediators, and even angiogenesis. So this beta amyloid accumulation may be part of what leads to macular degeneration. And one that's about to enter clinical studies is galimetics. This is a topical medication that binds to only misfolded beta amyloid monomers, preventing the formation of toxic beta amyloid oligomers. Preclinical studies have showed reduction in beta amyloid deposits as well as reduction in complement activation. And as I mentioned, this is entering clinical studies. Visual psychomodulators, unfortunately, in the past failed several large phase 3 studies. And the idea here is that if you could slow the visual cycle, this will reduce the toxic byproduct accumulation. But we're starting to see newer molecules, and these are all oral, which is what is exciting, that fail to reduce dark adaptation like the earlier visual cycle modulators and may have an effect on reducing geographic atrophy. In fact, Alkeus' product with deuterium-enriched vitamin A, which prevents the dimerization of vitamin A, has passed in terms of treatment in patients with Stargardt's disease. In fact, we may be able to see this drug for the treatment of Stargardt shortly, and the geographic atrophy study we'll hear the results of in the near future. Now, if you look at the ABC News, you know that stem cells will give you 20/20 vision, and that everybody should be on stem cells. And while this is certainly not true, the experimentation with different forms of stem cells is really moving forward at a very fast pace. The big question, of course, is how do you deliver the stem cells appropriately to the area in question, in this case, the area of geographic atrophy. In the beginning, we simply just injected these stem cells into the subretinal space and hoped that they would become the cells in question. But we've since learned that RPE cells are polarized as well as photoreceptors are polarized, and so maybe we need to put a scaffolding to allow for polarization and have a little extra differentiation of these cells, and even multi-layered stem cells are being tested. And these are all in clinical studies as we speak, including phase 2 studies with OpRegen, with Lineage Cell and Genentech Roche. The area of greatest excitement, of course, is suppression of inflammation using complement modulation. If you look back at the medical school teachings of what the complement system is, we know that there's 3 ways to activate it: the classical through an antibody binding, the mannose through lectin and microbial surface binding, and the most active, which is the alternative pathway, which is due to spontaneous activation. And these 3 pathways lead to different effects. Both C3a and C5a lead to an inflammatory response with chemotaxis, an influx of phagocytic cells, and other increases in permeability. The other aspect is the formation of the membrane attack complex by C5b, leading to cell lysis on the bacterial surfaces. And the alternative pathway works by causing opsonization or the placement of C3b on cells throughout the body, and in particular on bacterial surfaces, leading to opsonophagocytic killing. The first genetic associations in GWAS studies showed that many aspects of the complement system were activated in patients with macular degeneration. And histopathologic specimens have also shown that patients with macular degeneration have numerous components of the complement cascade. But as you can see, there's no one cascade that seems to be most involved in the activation. So where are we targeting? Well, one is targeting C1q, which is the activation pathway for the classical pathway. But C1q is also activated by other things, including beta amyloid. So this makes a good target, and Annexon is using an intravitreal injection of a C1q inhibitor, a phase. Historically, the activation of C1q in particular has been by an antibody-antigen complex. But in addition to that, C-reactive protein and beta amyloid can also activate C1q. And as I mentioned earlier, we know that beta amyloid is present in drusen. If we look at C1q labeling in macular degeneration patients, it is around drusen. So it makes sense that blocking C1q in the classical pathway may protect against photoreceptor damage. An additional body of work is the use of an anti-C1q to allow for neuroprotection. If we looked at neuroprotection light-induced damage models, the synapses and neurons are protected by the addition of anti-C1q. When we looked around geographic atrophy lesions, which are on slide right, and go away from it, you can see how both the RPE and photoreceptor layers get progressively thin the closer you get to the geographic atrophy. And this gradient of decreased function is the idea behind the use of C1q, because maybe if we could prevent these cells from dying, then geographic atrophy would be prevented or slowed. In the phase 2b Archer study, the primary outcome was a prevention of GA progression, and that was not met. But interesting pre-specified secondary outcomes were met, especially in the every month treatment. This is an every month monthly injection, in that patients had prevention of a 15-letter loss with these injections, and this was statistically significant. In terms of a functional analysis compared to this structural analysis of photoreceptor loss, it's interesting that even though geographic atrophy wasn't prevented, the prevention of EZ loss was by ANX007. And when we look at the patients who had the prevention of vision loss, this correlated well with those patients who had prevention of EZ loss. Based on these and other analyses, a phase 3 clinical program, the Archer 2, is currently underway, looking at monthly ANX007 versus sham injections in patients with dry macular degeneration. In addition, a second study called the Arrow study is a head-to-head study of ANX007 versus Syfovre, and this is based in the US for the most part, because in the EU, Syfovre is not FDA approved or EMA approved. What about factor B? Well, factor B is one of the rate-limiting steps of the alternative pathway. So if you decrease factor B activation, the alternative pathway is slowed. So using a subcutaneous injection of an RNA and interfering protein, basically we can reduce the formation of factor B, which is largely in the liver. A phase 2 clinical study is fully enrolled, and we expect to hear the results of this study shortly using the sub-Q injection. Now, thinking back, we also learned about inhibiting factor D. There was a large phase 3 study using lampalizumab that unfortunately failed. But there may be reasons why this failed, and other companies are targeting factor D, in particular Alexion, which is a company well known for complement modulation. They're using an oral small molecule inhibitor of factor D that crosses the blood-retinal barrier, and this is currently in phase 2 testing with the results coming shortly. Now, as I mentioned in the alternative pathway, it's this opsonization of all cells throughout the body which leads to killing. So it's important for us to turn off this opsonization in our normal host cells. Complement factor I and complement factor H are what are involved in reducing C3b opsonization. So as opposed to the other things I've talked about here, the goal of this is to enhance or replace the mutated complement factor I or complement factor H through gene therapy or recombinant protein injection. There was one study that has failed, which is a gene therapy to produce complement factor I, but other companies are also looking at using gene therapy to replace the mutated complement factor H and restore balance to the alternative pathway. C3b, of course, is where we saw the first FDA-approved product in the form of pegcetacoplan, and other companies are targeting C3b. The second FDA approval was targeting C5 by avacincaptad pegol, and in this, the membrane attack complex is the final pathway for preventing the formation of the MAC. So if you could produce soluble CD59, you could prevent MAC complex increase. Interestingly enough, in patients with macular degeneration, CD59 is actually decreased. And so the idea behind HMR59 is to use gene therapy to produce soluble CD59, and this prevents the membrane attack complex from forming. Another area of very interesting approach for the treatment of dry macular degeneration is this idea of cyclic receptors. Now, cyclic receptors are expressed on all our immune cells. They're basically a way for the body to tell self versus not self, and they serve as immune markers. They're like barcodes for our immune cells, in particular macrophages, to recognize what is our own cells versus a foreign invader. AVD104 is a nanoparticle that is coated in the sialic acid moieties, thereby having interactions with the immune system. They're very, very small, 100 nanometers, which allows for better tissue penetration. In addition, it has a very prolonged PK profile, which would allow an injection approximately every 3 to 4 months. AVD104 works by a dual mechanism of action. The primary activity is probably related to macrophage repolarization. So we know that in macular degeneration, macrophages are activated, and this is one of the reasons why we get damage to the RPE. AVD104 repolarizes these activated macrophages into a resting state, thereby preventing the damage. In addition, AVD104 activates complement factor H, thereby normalizing the amplification factors for C3 in particular, as well as C5, tamping down the complement system. In the early clinical study, patients had both a reduction in GA progression at 3 months, but more importantly, an improvement in visual acuity. When we look at the different cohorts, there was a nice dose response showing increased activity with the higher dose, in particular when we looked at GA lesion growth. In the second part of the study, which is currently ongoing, the drug is being performed head-to-head against avacincaptad pegol given monthly. The primary outcome will be at month 12. Similar to the way that Iveric Bio used their phase 2 study as a 3 study, this is being designed with alpha protection so that if it's positive, it will serve as the first of the phase 3 clinical studies. Cover is this idea of the sigma-2 receptor, which is activated by different stressors that I've already kind of talked about: oxidative stress, beta amyloid oligomers, and other inflammatory mediators. And so what Cognition is using is a oral small molecule that targets the sigma-2 receptor to allow us to reduce the effect of these stressors. Interestingly enough, both using light for photobiomodulation and low-dose microcurrent stimulation in the form of bioelectric therapy are also being tested. So I hope this is a good overview for everyone of the emerging treatments of dry macular degeneration. The reason there's so much going on is because we really don't have a good animal model, so the only way to test our drugs is in a human. The current strategies are targeting many things, including preventing oxidative damage, reducing photoreceptor death, and more importantly, suppression of inflammation, where we now have 2 approved therapies to reduce GA progression. But it's an exciting time in dry macular degeneration because many clinical trials targeting other pathways are currently underway. Thank you.
Thank you, Dr. Kaiser, for summarizing all therapies in dry AMD. Is Dr. Kaiser online? Has he joined?
Yes. Yeah, I'm on.
Yeah. So a few questions. We are already over time, but just one question from my side. How do you see patients fit for these new therapies? Now we know 2 FDA-approved drugs that have come out. So how do you choose the patients, right patients who will benefit from this kind of therapy?
Yeah, I think it's a difficult question, right? So currently, our current therapies require either monthly or every other month injection. And so that's a very difficult proposition for any patient, and it's difficult even for physicians to do that many injections. So we really reserve the use of those products to those patients who have lost vision in one eye, and in their fellow eye, their only remaining eye, they're starting to show progression, in particular faster progression, and we can see that over time on the OCT. So the fast progressors who have one eye, those are the patients we're treating universally. Now, there are other patients who've heard of the products and they'll want them even if they don't necessarily need them right away. And the reason for that is the effect is very minimal of our current medications. And hopefully some of the ones I discussed in the lecture will have a better outcomes, or be easier to deliver, like a pill or a drop, or maybe a sustained release injection. You know, that if that should occur, then more patients would be candidates.
Thank you so much, Dr. Kaiser. Because of time constraints, I'm afraid we'll have to move on to the next talk. Thank you so much, Dr. Kaiser, for joining us. Am I audible? Thank you so much, Dr. Kaiser, for joining us in due to time constraints, we'll have to move on to the next speaker.
Thank you.
Dr. Rachita, over to you.
Good evening, everyone. Welcome to Pan Ophthalmologica and to our session now on flaps, bags, and IOLs, the other side of vitreoretinal surgery. It gives me immense pleasure to invite Dr. Sifan Safran, a cornea specialist, a prolific surgeon with special interest in cataract surgery and premium lenses. Without further ado, sir, over to you for the talk on dead bags, zombie bags, and UGH, usual suspects.
Thank you. I'm going to share my screen now. Can you see my screen?
Yes, sir.
Excellent, excellent. So, I mean, in the United States, we have Halloween, so we celebrate the paranormal and unusual. This is some scary stuff I'm going to be talking about, so it fits into that. Dead bags, zombie bags, and the unusual suspects. I have no financial disclosures. So beware the dead bag. This is a thin diaphanous bag devoid of lens epithelial cells. There's no fibrosis at all, no capsule contraction. The zonules are disinserted, and this is prone to dislocation. And these bags, you don't want to try to lasso these when they dislocate because the whole thing will fall apart when everything shreds. These are dislocations that are removed and replaced with the scleral haptic fixation. This is a dead bag. This patient is about 15 years after cataract surgery. There's a thin diaphanous bag. The lens is floating in the vitreous. This is actually a psychiatrist. There was no lens epithelial cell cleanup done here. You can see this bag is just a wisp. We remove this and do Yamani, and the patient did very fine. Single piece acrylic IOLs within a dead diaphanous bag can actually cause UGG syndrome by iris chafing through the sheer anterior capsule. So this is a 78-year-old who was referred to me 10 years ago, 10 years after well-done cataract surgery, and she has an Acrosoft lens in the capsular bag, and she wakes up every morning with blurred vision due to microhyphema, but it clears as the day goes on. And she was referred by a retina group. They had no idea what was going on here. Everything seemed to be normal. She has progressive glaucoma, pressure 32 on COSOP. And this is what she looked like when I saw her. So I just had to wait around a few hours till everything cleared a bit. And you can see she has a thin diaphanous shimmering capsular bag, iridodenesis. The lens is clearly in the bag. And you can see she has these iris transillumination defects on both sides over where the haptics are. So I took her to the OR with a plan to exchange for a silicone lens. I had never seen or heard of a dead bag. This was 10 years ago, before this was a popularized subject topic. And when I took her to the OR, I took the old lens out, went to put a CTR in, and I could see that the capsular bag is just very thin and friable. I take out the CTR, try to replace it in the bag by hand, and I can see the bag is just collapsing. It has no structure, no strength. So I decided to do a pars-plana vitrectomy, and back then we were doing the glued-in handshake technique. This is before we had Yamani. This is back in 2015. And so I did a silicone lens, glued in, and she did fine. This is day one post-op. She's now 9 years out with no further hyphema incidents, and she's off all glaucoma meds. This is a physician who had recurrent vitreous hemorrhages. He was treated with pars-plana vitrectomy by retina, but he still had recurrent bleeding and glaucoma. But the physician cured himself by dislocating his lens bag complex onto the retina. After that happened, he didn't have any more hyphemas or bleeding, and his pressure started to come down, but he couldn't see. So these are the transillumination defects from transcapsular iris chafing. You can see them over the haptic insertion where the haptics had inserted, but now they're no longer there because the lens is on the retina. So I took this patient to the OR, and you can see I'm vacuuming the lens up off the retina, and I'm going to bring it forward, and the capsular bag is just a little wispy remnant wrapped around one haptic. But what's interesting is that when I take this lens out, you can see as the capsular bag comes out, it's studded with pigment, and that pigment was from the transcapsular UG when the lens was in the bag. So I wrote a paper on this topic with Minas Caroni and Erica Darian Smith on capsular bag disorders, where we discussed the dead bag. And it turns out there's a complex interaction between basement membrane, lens capsule, and lens epithelial cells where they sustain each other. Dead bag lens epithelial cells are left behind by the surgeon, but they wither on the vine and die off. The capsular bag loses integrity. The zonules have nothing of substance to insert into. The bag dislocates over time. And it's sort of like soil that you plant seeds in, but nothing grows. There's no trees to sustain it, so then there's soil erosion. Does removing lens epithelial cells lead to dead bags? No. Removing lens epithelial cells, when you do remove them, are from the anterior capsule. It doesn't remove the equatorial lens epithelial cells, and these lens equatorial cells proliferate and cause PCO. And that's really the rationale for sharp-edged IOLs that sequester the posterior capsule and reduce posterior capsular fasciculation. Removing LECs from the anterior capsule has no effect on PCO rate. There's plenty of studies that show that it just reduces anterior capsule contraction and phimosis. In dead bags, the LECs left behind by the surgeon wither on the vine, and the bag loses its structural integrity. Now, if you could remove all LECs, it might lead to loss of capsular integrity over time, but we can't do that during surgery. So what's a zombie bag? Well, a zombie bag is only partially dead. The bag is still standing. The posterior capsule is dead. It's lost its functional integrity, but the anterior capsule and zonules are intact. There's variable capsular bag fibrosis and some ring material present. And we see this in lenses that have been sequestered in the bag for many years when we go to exchange them. Even in the presence of anterior capsular fibrosis and intact zonules, the posterior capsule, which is isolated from lens epithelial cell by a square-edged lens, can become dead and shred. So here I'm injecting viscoelastic to do a lens exchange, and look at how that posterior capsule just shreds and falls apart because the posterior capsule is dead. This is most common when you have a sequestered posterior capsule that's crystal clear. You can hardly see it. And the bag itself is intact, but not the capsule, which has lost integrity. Here's a patient referred from Australia, a calcified oculentus hydrophilic acrylic lens, LP vision in this eye. Her visit to me was first delayed by the pandemic and then treatment for breast cancer. And during that 3-year period, this eye progressively got worse. And the other eye implant also calcified. So she's actually functionally blind now, LP in one eye and 2200 or count fingers in the other eye. So look at this calcified lens. It looks like concrete. It's a plate lens. It's a tight fit in the capsular bag. I'm going to go ahead and maneuver this out of the bag, cut the lens in half, take this out, and something very interesting happens when I go to put the new lens in. I'm going to dilate the capsular bag with viscoelastic, inject the new 3-piece lens into the capsular bag, and look at how this lens dissenters in the capsular bag way off to the side. This is happening because she has a dead posterior capsule. The posterior capsule has been sequestered. There's no lens epithelial cells, and the bag withers. The posterior capsule sort of withers on the vine, loses its integrity. Here you can see the posterior capsule actually wrapping around the lens. It's not broken. It just has no structural integrity. It's floppy. So I made a decision to reposition this lens in the sulcus and optic capture the lens behind the anterior capsule, which is a very secure configuration. I then decided to do a pars plana vitrectomy for floaters, send it back to Australia. The other eye already had a floaterectomy, so we planned to do this. And you can see this lens is very stable. This is not a dead bag, it's a zombie bag, okay? This is day 1 post-op. She did very well. We then exchanged the other eye. Now, single-piece acrylic haptics can also erode through the posterior capsule when it becomes like this and cause UG syndrome through uveal irritation. So this is a 68-year-old referred from upstate New York. He had cataract surgery with Restore lens 10 years earlier in both eyes, 13 years earlier. Repeat vitreous hemorrhages only in this eye from UG syndrome causing vision loss. Status post-pars plana vitrectomy, but it recurred. Acrosoft Restore is in the bag, and the local surgeons put a 0-power piggyback lens in the sulcus, hoping it would provide a barrier between the lens and the iris, but it didn't do anything for the patient. He kept getting hemorrhages. The other eye has no problems, has a restore in the bag. And so he sent to me from a few hours away, and I decided to watch him for a few months, but he returns with count finger vision and vitreous hemorrhage. So something has to be done. And the question is what? So let's see what happened when we took him to the OR. He doesn't dilate well. We put in iris retractors. We removed the sulcus piggyback lens. It's a plano piggyback lens. We go ahead and remove that. And we see that there's this lens here, this restore lens. It's a single piece acrylic, and this haptic is well fibrosed. I'm going to go ahead and cut this haptic. There's blood in the eye because he's had previous vitreous hemorrhage, but the other haptic's just swinging freely. It's eroded through the posterior capsule. This patient has not had YAG laser. The haptic is just eroded through the capsule. So I remove the lens, take out this haptic, and now I'm going to use iris retractors to retract this fibrotic anterior capsule, inject a three-piece lens directly into the optic capture configuration, drop this haptic in position. I'm actually going to expand the rexus opening a bit with the 25 gauge vitrector and complete the vitrectomy, remove all the blood in the eye. And this patient actually did very well. This is day one post-op. You can see the lens is very secure, optic captured. He's 1 year out now with no recurrence of bleeding and off all glaucoma meds. The haptics can erode through the dead posterior capsule and dislocate the lens into the vitreous. And we're seeing more and more of these cases. This is a patient, never had YAG laser. The lens is gone. When I go in to do a vitrectomy, the lens, I'm fortunate, just floats up and comes into my grasp. I'm able to take this lens out, bring it up, cut it into the two pieces, take it out. You do not want to try to optic capture when you have a dead bag. This is a dead bag. I felt it was best to just go do Yamani. So here I am. I'm going to put my new lens and do Yamani. I melt my flanges, push the lens in place, and you'll know I make a peripheral iridotomy in this case. It's very important to make a peripheral iridotomy for all scleral fixated lens. Please make at least one PI, and this is to prevent reverse pupillary block. Reverse pupillary block can occur with vitrectomized eyes with sulcus lenses, and this can cause UGG syndrome. And it's due to a one-way ball valve effect of iris in contact with the lens. You can get dramatic posterior iris bowing against the lens, leading to hyphema. This causes recurrent optic capture by the iris, and it usually resolves immediately with the laser iridotomy. This is what it looks like with the gonio lens. You can see the concave posterior bowed iris. And there's a patient with UGG syndrome on OCT. It's a lens in the sulcus. The iris is in contact with the lens and bowed back. And after a PI, the iris flattens out, and there's a gap between the iris and the lens. So what is the mechanism of this? Well, when you create a laser PI opening for reverse pupillary block, you see the opposite of what you see with regular pupillary block. Instead of a gush of fluid into the AC, you see the pigment and fluid sucked back out of the anterior chamber. And this is an indication that the IOP is higher in the anterior chamber than the posterior chamber, and you have basically a compartment syndrome with higher pressure in the anterior chamber than posterior chamber. This causes iris stretch and chafing, UGG syndrome with blood pigment block TM, and you get a vicious cycle with elevated pressure, and it's relieved with either optic capture by the iris spontaneously or by making a PI. So the simple question is, how can the pressure be higher in the anterior chamber than the posterior chamber? And there's only one way this can happen. Aqueous flow has to reverse direction in these cases, and we can prove that it does. Every single patient, myopic eye, I've done Yamani on, pars plana vitrectomy and a sutured lens with normal intraocular pressure, you will see reverse aqueous flow. You'll see the pigment flowing backwards like you do here. And here's another case. You can see these pigmented cells going from front to back. There is reversal of aqueous flow. And that's what leads to reverse pupillary block. And this is why we get this pigment dusting on all of these lenses. This is a Yamani patient, a month or two out. There's pigment on the lens. And the reason you get this pigment on the lens, when I clear it with the YAG laser and dust it away, you can see there's reversal of aqueous flow. And this coats the lens with this pigment until it kind of run out of, loose pigment. And the process sort of, you don't have to keep yagging the pigment off the lens over and over. So the zombie bag, only the posterior capsule is dead. It's lost its structural integrity. The anterior capsule is still intact with variable fibrosis present. The zonules have good integrity. This may represent a transitional phase, or more likely a sequestered posterior capsule that loses nutritional support and or necessary biochemical trophic interactions with lens epithelial cells. And this may lead to dislocation or UG syndrome due to haptic extrusion. Thank you very much for your attention.
Thank you, sir, for that insightful talk. We all have had these issues where we are not happy with all our secondary IOLs, and especially what you said, all our IOLs where we have these pigments on even the scleral fixated that we do glued or we do Yamane, we always have these pigments on it. I've also started doing a PI and I've realized that results are better. I was having for some period a very troublesome cystoid macular edema developing in all my secondary or the scleral fixated IOLs that I used to do. I used to initially think it was just maybe inflammation post the secondary IOL, but then with this PI technique and things are getting better. So thanks a lot, sir, for your insights. Any other questions from our participants?
I'll mention that in high myopes, it's sometimes important to do more than one PI because the high myopes have more. We've actually know why there was a reversal aqueous flow. It would take about 10 minutes for me to explain it, but there is a physiologic reason for why aqueous is reversing flow. Actually, normally the retina, there's a significant amount of aqueous outflow through the retina, through the RPE. And when you remove the lens barrier, the lens, so the complex, and remove the vitreous, you increase that amount of flow. And with myopes, you have more flow. This is why if you have a retina detachment, the pressure drops. This is why you put in silicone oil to pump the eye up. So, there's other reasons too. There's a whole series of things I can lay out, but I don't really have time for it here. But in vitrectomized myopes, you may need more than one or even 2 or 3 PIs, and it also may be positionally dependent on where you place them. If you do a real complete vitrectomy and you put the lens a little bit back of the iris and make PIs, I have a very low CME rate with my Yamane technique. I really almost hardly ever see it unless they had CME beforehand. If going in, they have an anterior chamber lens, they have a dislocated cataract on the retina or something, somebody dropped the lens and, they come to you with cystoid macular edema already, then there may be some persistent problems after surgery. But I find actually taking out the offending lens nucleus or ACIOL or dislocated lens, replacing it with Yamane, doing everything with a good, full vitrectomy, cleaning everything up. I think that we have lower CME after surgery than before surgery.
Thank you so much, sir. We'll over to Dr. Kshitij to introduce our next speaker for the evening.
Hello, everybody, and welcome to Pan Ophthalmologica. Next, we have Dr. Gustavo Huning from Brazil with his presentation on 2 IOLs and 1 solution, the twins. Dr. Gustavo needs no introduction. He is the recipient of Red Buckler Award on multiple occasions, and his presentations are always very fascinating and we always look forward to them. Over to you, Dr. Gustavo.
Dr. Raizada, good morning. Thank you so much. Thank you for the invitation to Pan Ophthalmologica, especially Dr. Vaibhav Sethi, who was kind enough to invite me. And the video we're gonna present today, it was one of the Red Buckler's Award winners from this year in the ASRS. So let's play the video, and after that, I'm open to questions, as requested by our friend Vaibhav. Please.
This is a patient who was referred to us due to a fallen IOL into the vitreous cavity. So the idea is to perform a complete vitrectomy that involves a good shaving of the periphery, with the use of triamcinolone to help us see the vitreous better, with scleral indentation. Once this part of the work is done, we decide to go down. But
I'm your brother, Julius.
Huh? Come again?
My name is Julius, and I'm your twin brother.
Oh, obviously. The moment I sat down, I thought I was looking into a mirror.
We are not identical twins.
Oh, no?
in the same way that Julius took Benedict by surprise, we were surprised to see two different types of IOL on the macula. At first we thought it might have been a failed piggyback, but since we had not received accurate data about what really happened, our surgical plan was limited to a single but important exam that all of our aphakic patients undergo: biometry. Once we knew it, we have decided that we would remove the single piece and use the three pieces IOL to make a secondary implantation. With a vertical scissor, we decided we would use the Pac-Man technique to try to remove the IOL. But our first attempt wasn't very successful because we had an haptic rupture. So, we decided to go deeper with the scissors to cut it a little bit more and then try to bring it again with a special forceps, bringing it and removing it in a 3D way, not just to the sides, but also lifting it a little bit to avoid trauma, since our incision was at 2.75. Now that we have removed out one of the twins and exposed it on cornea, it's time to go down, to get the other lens and perform a Yamane fixation, a technique that requires as much delicacy as the twin brothers dancing with the twin sisters. To bring the IOL up, we use the distal haptic technique, which makes much easier to work with it. Remember to have two microforceps serrated much better because of its stability, and bring one of the haptics out and the IOL to anterior chamber so you can prepare the eye for the implantation. In this case, we are using a 25 gauge needle, and we recommend passing the microforceps through the paracentesis. Otherwise, if you go through the main incision, you will decompress the anterior chamber and make things more difficult. Once we have docked it, we gently pull the needle. Slowly, to avoid to have to redo it, and then now we are going to make the first flange. Now it's time for the second step. Remember to pass the needle through a symmetric point considered the first one from the previous haptic. Gently dock the haptic inside it, and pay attention because sometimes you might bend the haptic. Now gently with a microforceps, again through the paracentesis, bring it out slowly, avoiding to push it too much, otherwise on the other side the flange could pass the sclera, and hold it with the forceps. Once you have done it, make the flange, but pay attention. In this situation, due to the bent haptic, we decided to trim it and redo the flange. Otherwise, the optical zone of the IOL will be not very well centered. Now that the hardest part of the job has been done, it's time to start removing the trocars and to inject carbachol to check if the center of the pupil will match the optical zone of the IOL. and we can clearly see that we have done a good job. So, hydrate incisions, suture the sclerotomies. We want to avoid endophthalmitis here since we didn't perform the fluid air exchange. And remember, safety is our number one concern. Thank you so much for your attention. Very well, my friends. Here we are back to any questions you might have.
So this video as well as the picture is definitely worthy of recognition by the ASRS, and I have had the
Thank
good
you.
fortune of having witnessed this video and the picture at Stockholm this year. I wonder if you remember it or not. We accidentally bumped into each other at the Grand Hotel during the opening ceremony at Stockholm in July this year. And I just wanted to know how did the patient actually land up with this scenario? It's something very unusual, and we don't see this on a daily basis.
Absolutely right. It was actually, I was really surprised. To explain you my reality, I work in two places, a private hospital, and I'm only the only one VR surgeon for a population of 2 million people in the public system, okay? So many of these patients come through the system of the government. I don't have contact with the doctor who had performed the surgery because it's not they are not referred from doctor to doctor. They are referred through the system. And I didn't have much data about this situation. I don't know if it was a piggyback or if it was a leap of faith from the colleague or he tried to change the IOL. But the thing is, it was not a piggyback because of the biometry, right? It was 23. So it was for sure an unusual situation.
And did you have any backup plan in mind, just in case you might would have ended up with a broken haptic while doing the Yamanes? So did you have any backup plan in mind?
Absolutely, absolutely. The original idea was to use the same IOL, but since we had done the biometry before the situation, we had a backup three pieces IOL. And here we work with 2 or 3 different types of three pieces IOL. I wish we had the Carlevalho lens. Carlo is here, but we don't have it in Brazil. And so this is the best situation. Other plans, I could have also sutured the IOL to the iris, which I don't like very much, or to the sclera, but there was plan B, C, D, and further.
Excellent, excellent. Thank you so much, Dr. Gustavo, for your insights on this rare case. And in the interest of time, we would like to move over to the next presentation. And I would like to invite Dr. Vani so as to introduce the next speaker. Thank you, Dr. Gustavo.
Thank you.
Hello, everyone. Welcome to Pan Ophthalmica Session 3. I think I'm not seeing Dr. Athanasios Nikolopoulos online right now. So we can straight away move to the next talk, which is by Dr. Andre Zuka. We welcome you, sir, and we like to start your talk in the interest of time on LASIK flap dislocation during VR surgery. We are not able to hear you. I think you need to unmute.
Can you hear me now?
Yes, yes. Now we are able to hear you. Thank you.
Oh, I was thanking the organized committee for the invitation, and I'm going to share with you two cases of LASIK dislocation during vitrectomy surgery or vitreoretinal surgery. We know that LASIK flap never really heals fully to original strength, and it may become dislodged during or after vitreoretinal procedures. It's a rare complication, but since we have more and more patients that undergone LASIK and more patients that are going to have vitreoretinal surgery, this rare incidence is becoming more common. The causes of dislocation may be fluid turbulence, cornea manipulation, or even accidental stress.
Sir, it's muted again.
Sorry.
Yes.
So the first case, let me just take it back. The first case is about an accidental bullet that was, and a small bullet that ended through the eye near the nose of the patient. And this is the second procedure where after suturing the eye globe in the emergency room, we got the patient and the eye was really bad. And the patient have a retinal detachment, and we are going to fix this retinal detachment in this first surgery. So the cornea was a little bit cloudy, and we thought about removing the epithelium, but instead we remove all the flap. So the patient had a LASIK for myopia some years before. So we did just remove the flap, and this was in a way a good thing because it cleared the view, because the cornea was so hazy that we couldn't see very much. And now with the flap put just visco over the corneal stroma, we get a much better view. We removed all the blood and that there was inside the eye, put perfluorocarbon fluid and do a 306-degree cerclage, laser cerclage to this patient. We didn't do any buccal in this case, and but it ended very well. The eye was okay. After we intend to do a second surgery with artificial iris and an implantation of an intraocular lens. But at the end, the procedure is just put back the flap, and this is just 5 days after the procedure. So it was kind of a surprise because we didn't expect that. But in the end, it was good because it really cleared the view. The second case that we had happened.
Excuse me, sir.
Again?
Is the screen sharing on?
Yeah, are you not seeing my screen?
No, sir. We are not seeing the slides.
No, really. Let me just. Can you see my screen?
We can see a calendar.
Oh, just a calendar.
Yes, sir.
But you were seeing my screen before, or no?
No, sir.
No?
No, no, no.
Oh. Okay, let me try to. Can you see my slides now?
Not yet, sir.
Not yet, sir.
Not yet. Let me just. Okay. I don't know what's going on. Let me just try to. Can you see my slides? No.
Not yet, sir.
Okay, I'm just trying to close everything. And Zoom. Okay, just okay. Okay. Now, can you see it?
Yes, sir.
Now it's good. Okay. So the first case was this case. So let me just increase a little bit. Okay. So the first case was this bullet. This was a party, a big party in Brazil, São João party, and the bullet just got through the eye, and the patient got a retinal detachment. So this was the second procedure. We tried to remove the epithelium. Are you seeing it now? It's good?
Yes, sir. We can see it now. It's clear.
Okay, so we just removed the epithelium, and as you can see, it was very cloudy. We could not see very well, but when we were removing the epithelium, we got this kind of surprise because the patient have a myopic surgery before, and the LASIK flap just dislodged. There was this displacement was good because now we can see much better, as you can see. And we just remove all the cataract remnants and the vitreous and the blood that was in the periphery of the eye, of the retina and back of the iris and in the pars plana. We removed everything. And then we put perfluorocarbon fluid in the eye and did laser cerclage to avoid misses, small ruptures, since the view was not the best, even though it was much better. You see there is a small amount of blood in the posterior pole, but this was not a big deal. We decided not to go through removing this very small amount of blood. We just put SF6 in the end of the procedure, and then reposition the flap at the end of the procedure. Just did that. This is very easy. You just put a contact lens, and this is 5 days after the procedure. So this was the first case that we got this surprise. Of course, this is a multi-step procedure, and we make sure that the intraocular foreign body was not in the eye, and was in the nose. The bullet just go through the eye and stopped at the nose. There was a very small bullet because they were playing in this part with the gun. And then we decide not to amputate the flap, and this is a very important decision to take. And the second case that we have, we were doing just a routine case of this was a young guy with inferior retinal detachment, with macula off retinal detachment. We just did this silicone band and with drainage, and it was just a routine case, as you can see. It was not something special, something that we do very often. And we, in some of these cases, we prefer to use endolaser, but we noticed that when we are moving the eye, the LASIK flap just dislodged itself. So we just, again, remove it and did the underlaser. And then we just sutured this. This is a 25 gauge illuminated probe from Alcon. And we just sutured the conjunctiva and just reposition the flap again. It's not very complicated. You just have to put a contact lens, and we will just come back to this original position. Just do not amputate the flap again, because it will change the refraction greatly if you remove the flap. So that's, again, another surprise, but this can happen in these patients. So we must have always the information about previous refractive surgeries, since we have to pay attention to this flap in these patients. And sometimes we are so focused in posterior segment that we forget to note this in the operation room. With many patients, we just can forget who had myopic LASIK. But if it happens, and sometimes it's not bad because you have great view with the stroma only, since there is no epithelium edema, you just remove the flap from the visual axis and move on. And just reposition the flap at the end of the procedure and do not amputate the flap because this will change the refraction greatly. So there was this two scenarios that I brought to you. And I hope that if you met like myself in this situation, you can just remove the flap and move on with the surgery and just reposition it afterward. It's not very difficult, but it's something that we are seeing more and more often with more and more patients undergoing LASIK and vitreoretinal procedures. Thank you very much. And I'm sorry about the troubles with the transmission.
It was a wonderful presentation, sir, and wonderful documentation of both the cases. Really, the first case was a gunshot injury. So there, the corneal edema and everything may arise a little bit of suspicion. But second was just a simple plain scleral buckling procedure. But here also the flap dislodged, just to prove that it can happen anytime. But yes, sir, that's both cases very well done, managed and documented as well. For me, sir, we have documented one case where the LASIK flap dislodged about, say, 6 months after the LASIK procedure was done. And the patient was supposed to post it for a barrage. And it was done with a contact lens. That time, while removing the lens, the flap again dislodged. But as you said, we had to reposit it back and put a BCL, and it finally kind of gradually cleared up. Just one question. When do you remove the bandage contact lens when you put it once?
Well, you just remove it in the next day. It can stay for a longer time, but it's enough if you, in the next day, in the first day post-op, you just remove the contact lens. It's in position again. The point is, even it is 10 years, 15 years after the surgery, it never heals to the original strength. This is just the epithelium that is holding it,
Yes.
and then it's easy displaced during the procedure. If you move around the eye, like in the first procedure, you just try to remove the epithelium, it may dislodge. So just make attention and do not panic, because at first time what's going on, and then you realize that's no big deal. Just reposition it, and everything is going to be just fine.
Thank you. Thank you so much for the great insights. Any questions from the other participants? I think
I would like to ask one thing, sir. So, are there any post-operative refractive changes once you reposition the flap after the surgery?
No, there is a big change in the refraction if you amputate the flap. If you take the flap out, it will heal, but the refraction is going to be much different because the cornea is going to be much more plain. So the cornea is like 40 diopters, is going to be like 34. So the patient is going to get a big, huge change in. And this patient that got refractive surgery, many times they are worried about their refraction after the surgery.
Exactly.
Thank you. Thank you very much. Over to you, Dr. Isha.
Thank you so much.
The next speaker.
Yeah, it's actually a great honor for me to introduce Dr. Carlo Callevel. He himself, the man himself who gave us the Callevel IOL, the one which was discussed extensively earlier in the sessions also. I welcome you, sir, and we wait for your talk. Please illuminate us with the complications of the IOL which you yourself have invented.
Thank you, Isha Agarwal, for the kind presentation. Thank you to all the organizing committee and Viva SETI for the invitation. As any procedure, even the Carlevale IOL that I have developed on 2012 may have some complication. I want to share the screen, okay? I think you can see it.
Yes, we can see your screen.
Okay, let's start. We can divide the complication in intraoperative complication and postoperative complication. The intraoperative complication can be due to the lens, so IOL rupture, IOL opacification, IOL dropped, or due to the forceps, because wrong or sharp shaped forceps or defective working forceps, or a complication due to the architecture of the scleral flaps, scleral pockets, and scleral holes. Let's start with the damage, the IOL that are damaged. One of the main reasons of the IOL damage is the mistake in loading of the lens. This is a big lens, big loops, so overall diameter 13.4. So if you are careful, you can catch some part of the lens between the cartridge of the two wings of the cartridge, or between the cartridge and the rubber piston. So you may deliver the lens which is already damaged inside the eye. You should use a less traumatic as possible forceps. So Eckhart, not suitable. Sharp crocodile tip, they will damage the plaque. So ideal are just a plain optic, not sharp. Now, what will happen if some part of the lens can get damaged? If you damage just the plaque, the ideal is to suture the plaque with the Prolene 10-0 suture with a curved needle, and stitching the suture to the scleral flap. If you break one of the four fingers, they are connecting the optic part with the loop, you just can leave it because the lens is extremely stable. If you break the optic part, is a peripheral area, you can leave it. If it's central, anyway, you have to remove it and replace it. Now let's start some video of complication. I should divide the Carlevale IOL implant in two kind of eye. The eye fully vitrectomized and the eye partially vitrectomized. The eye partially vitrectomized, they can be, there is much less risk of lens drop, because if you put a pillow of soft viscoelastic, the lens will float above the iris plane, and there are less chance that the lens will fall down. If you have a fully vitrectomized eye, you may have a much higher chance of lens drop or lens diggling. You may see this complication from our two colleagues. The lens is diggling, just one side is engaged to the ciliary sulcus, and the other side is diggling. In this case, it is ideal to have a fully vitrectomized eye. As well, if you drop the lens down to the vitreous, you need a fully vitrectomized setting. Anyway, if you stretch the lens too much, the lens is extremely elastic, but if you elongate a lot, you can snatch it. In this case, it's just the limit of snatching, you see, of stretching, a little bit more, and the surgeon would have been snatched the T-shaped plaque. Anyway, the architecture of the wound. In this case, the surgeon has a big blade, and on the way back is enlarging the wound. So the wound, the hole in the sclera is bigger, and so the T-shaped plaque can flow back in the vitreal cavity. you may see here 3 instruments because the assistant of the surgeon then is holding the plug just to avoid that the plug will flow back in the vitreous cavity. But this is the most common complication due to the corneal folds, due to the bleeding in the anterior chamber. The beginner surgeon engaged something which is not a plug, which is just a side of the loop. We should remember that the loop is a bigger loop. So what will happen now? Okay, you may see here the loop, and the plug, the T-shaped plug, is like an harpoon, is opened on the side of the ciliary sulcus. There are 3 chances, 3 choices. Just to push back everything and try to engage, to grab with your forceps only the T-shaped plug. But you may take the risk that the lens will be falling down in the vitreous cavity, will be diggling. Or, like in this case, the surgeon just stitches the loop on the bottom of the scleral bed. It will be the scar of the sclera to hold the lens. The lens will be slightly to the center, but this is a 6.5 diameter lens, so even a slight decentration will not affect on the visual acuity. Or like our Greek colleague Stylianos Kandarakis, which is presented this video several years ago in the American Academy. He had the same problem, the same mistake, and slowly and patiently he is pulling in one side and then in another side, but you may see the hole is relatively big till the plug pops. You may see one side, no, other side, the plug pops on the surface of the scleral, the bed of the scleral flap, and the procedure is practically finished. Again, if you make a big hole, just stitching and wound will be smaller. This is where there was a case that was referred to me. There was an erosion of the T-shaped plug because it was not properly covered from sclera. You may see that one of the 2 sides of the plug was broken. What I did, just I sutured with the Prolene 10-0 the neck of the T-shaped plug. Then I pushed back at the level of the ciliary sulcus the T-shaped plug, half of the T-shaped plug. You may notice how a powerful fistula it creates the plug if you don't cover carefully with the sclera. And then with the hand of the suture, I stitched the scleral hole together with the T-shaped plug at the level of the ciliary sulcus, and the lens is stabilized to the ciliary sulcus. One other important complication is the plug decubitation, is the plug surface erosion. You may notice that even if you insert other devices, you see that a glaucoma devices just behind the sclera at the level of the scleral limbus, the devices, they tend to erode or to create a thinner sclera, and this should be this aspect should be studied in future. What I suggest you, this is my ideal scleral flap, very big and very large scleral flap. So all the plug, all the T-shaped plug, which is long 2 millimeters, is fully covered. I would say 4 by 4 is the ideal size of the T-shape of the scleral flap. You may notice even on the other side, the flap, which is noticed very thick, cover carefully and safely all around the plug, one side and the other side. This reduces a lot the risk of plug decubitation. You may notice here that I was repairing plug decubitated with a piece of scleral from the same patient, but this is longer and leave a part of the sclera of the patient which is relatively weaker. There is our colleague Mohammed El-Alfi, which is using routinely bovine pericardium patch just to cover the plug and to repair the decubitation. Then in the end, we have to talk about the lens opacification. The old model of this lens is fully hydrophilic, so has a relatively high risk of opacification. You may notice here silicone oil with removed with the IOL implant. On the other side, small dust because the silicone oil was already removed. The lens was implanted secondarily, and still there are some dots. This is a courtesy of Stratos Gotsaridis, which is implanting a lot of this lens. This is a fully hydrophilic lens again that after 10 months was completely opacified. He report also another case that only with the opacification of the loop, you may notice. But even the new model at least has a much less chance of opacification. The new model is hydrophilic inside, but is hydrophobically coated. But there is a theoretical risk of opacification. But at the moment, there are no report of opacification of this kind of a hydrophobically coated lens. In the end, I want to present a video of our colleague, again Greek colleague, Evangelos Manousakis, who is showing how easy it is to remove this lens. We need infusion line, we need microcoaxial forceps, strong microcoaxial forceps, and with a hook, a big hook, you can pull it and luxate the lens without breaking the lens itself and without leaving any part of the lens in the anterior or posterior chamber. That's it. I hope that we had a good overview of the complication of the lens, and thank you to you and thank you to all the audience for attending it.
Thank you so much, sir, for such a wonderful talk. You illuminated the complications at every step which a beginner would actually have while doing the surgery. I
Yes.
wanted to ask one thing. Why was the IOL extracted in the last case? What was the indication for removing that IOL?
It was opacified.
Okay.
You could not see clearly, but it was opacified. So that's why it was an old model. It was the hydrophilic one.
Okay, so you have then replaced it with another similar IOL of the new
Yes.
model.
No. The new model is hydrophobically coated, and very soon it will arrive the fully hydrophobic model one.
All right. And one more thing, one of the complication you had shown when the T plug is pulled out primarily because of the traction, it can break. So
Yes.
how does a novice surgeon decide about how much pull they have to do so that the slender T doesn't break?
Absolutely. The ideal thing is to engage the plug and then pull it and just hold it, lift the flap and gently remove and check the hole. Once the plug appear outside the surface of the sclera, immediately release the forceps, and there are very low chance of T-shaped plaque if you manipulate carefully.
All right. And have you ever seen some iris pigment getting deposited on the IOL?
No. I have seen some iris chuffing because the lens from some colleague, because the lens was inserted around 1.51 away from
Limbus.
the limbus. Yes, so there is chuffing. The lens has a vaulting of 10 degrees. So if you position the lens at 2 millimeters from the limbus, there is very, very low risk of iris chuffing and pigment dispersion syndromes.
All right. Wonderful. Great talk, sir. If any other participant has any questions, they are welcome to ask, sir. All right. So this was the last session of
Yes, I
policy,
understand.
IPC,
You're correct. Yeah, I
and
understand. I think it's
no, but
late there.
it was a great amalgamation. There were speakers from all over the world, and it was a very well curated program. And the last talk was amazing ending to this great session, actually. Thank you
Thank
for
you,
that
Isha
talk.
Agarwal. Thank you,
Thank
Isha
you. Thank
Agarwal.
you.
Thank you, everybody. Thank you,
Thank you,
everybody.
everyone.
Thank you, everyone, for this very insightful and great learning this evening. Thank you, Dr. Carlo.
Thank
And
you.
yes,
Thank you, everybody.
thank you. Thank you,
Bye-bye.
Weber.
Bye-bye.
I
Bye-bye.
think for pulling us all on board and listening to such amazing talks from everyone. Thank you. Good night.
Good night,
you.
everybody.
Bye.
Good night.